discussion. Okay, we will go into a discussion. So before going into the discussion, one thing I want to tell here is, here today you had a session of quiz, right? You had a session of quiz, and in that quiz, is it audible? Is it audible? So today, so we are going to have a discussion on the important topics, okay, which I felt very, very important, and how to crack the exam. That was the thing which I was thinking. Okay, so with this, I will go into the important topics actually. So here, whatever we discuss, whatever we do, okay, is going to be based on how we are going to approach things. Okay, how we are going to approach things. Okay, if you are approaching in a right way, in a right manner, nothing can stop you from going ahead. Okay, nothing can stop you from going ahead. Okay, so that is the main thing. And one more thing, what we feel every time is, we have fear whether I can succeed, whether I will get the seat of my choice. Okay, that is one thing which will always try to suppress us from getting above. Okay, so one thing what I want you people to leave behind is the fear. Okay, if you leave behind the fear of the feel that whether I will be able to succeed or not, no one will be able to stop you. Okay, so the main thing is, you just leave the fear whether I can succeed or not. Okay, if you are not succeeding, then who is going to succeed? Okay, if you are not going to succeed, then who is going to succeed? So always bear in this mind that you are the one who is going to succeed, and whoever behind you is going to never cross you. Okay, that spirit you should develop to succeed in NEET exam, not only NEET exam, in your life. Okay, and all these questions you would have seen today, right? How you felt about the question? What is your thought about the question? So you can first share the thought about the questions came today. How you felt it? So I'm getting things that it's difficult. Yeah, bit difficult, lengthy. Felt as a diagnostician, mixed, lengthy, moderate. Okay, so actually I wanted the question in such a way that it is going to help you in your exams. Okay, that is the main aim of this discussion. Okay, I want you all to be concentrating properly in such a way that you are it is going to help you in your NEET-PG exam in coming months. Okay, that is the main aim. Usually quiz will be like single liners, right? It will be of single liner types. Okay, but this quiz was not like that. Okay, it was more typical of pattern where we had a lot of clinical questions. So that was the main aim of this. So this was the first question which was asked. So now you will tell me the diagnosis, and then we will go into the why it is associated with this answer. We will see. But before that, you are going to tell me what made you to think the answer. Okay, what is the key clinchers given in this question? Okay, so this is a 69-year-old female patient. Okay, and she is a case of rheumatoid arthritis on TNF alpha and some other treatment which gave her some kind of improvement. Okay, and she also had kyphoscoliosis, and FE1 by FEC is 86% and FEC is 55%. So based on this, it looks like a restrictive lung disease. Okay, so we have two kinds of restrictive lung disease which we have already seen. The first one is going to be an intrinsic one, and the second one is going to be an extrinsic one, right? Intrinsic and extrinsic. Okay, so our patient has kyphoscoliosis and also on treatment with some drug for rheumatoid arthritis. Okay, so what made you to think this case has a decreased TLC with a decreased DLCO? What made you to think like that? So this patient is having interstitial fibrosis due to rheumatoid arthritis. So it is going to be a non-specific interstitial pneumonia where the patient is going to have a decreased total lung capacity. Whenever there is a fibrosis, what is going to happen? What is going to happen? The DLCO is going to be decreased. If this scenario is not given and they have given DLCO is normal, then what you would have thought? If DLCO is normal, then what you would have thought? The same scenario with the DLCO normal, then you would have thought that it is a case of extrinsic restrictive lung disease. Okay, so hope I'm clear with this, right? So we have already seen this, how it is going to affect the different volumes. Okay, different volumes, what is timed vital capacity, everything we have seen already, right? So this is very, very important to know. Okay, this is very, very important to know. Okay, so this is going to help you in solving lot of questions, and we have seen in lot of our regular class also how this is going to help you in exam. Okay, how it is going to help you in exam. Connect ஆயிதான் இருக்கு. Hello. So this is going to be having 88% of this one. Okay, so you have told like this, right? So here, this is an alveoli, and this patient is having an NSIP. So what happens in NSIP? There is going to be a fibrosis here. Fibrosis here. Whenever there is a fibrosis here, what is going to happen here? The CO, carbon monoxide, cannot enter here. Okay, so what happens to the diffusion here? Diffusion is decreased. Okay, and whenever you have a restrictive lung disease, what will happen to the lung volume? Lung volume will be reduced, right? The lung volume will be reduced. So lung volume is reduced means then what is going to happen to the total lung capacity? Total lung capacity is decreased, right? Total lung capacity is decreased. So this is what happens in a case of rheumatoid arthritis with interstitial lung disease. Okay, interstitial lung disease. Okay, coming to the next question. So this question, what was your answer? This question answer is yes. So what is melanoptisis? What is melanoptisis? Melanoptisis is black pigmented sputum. Okay, black pigmented sputum, when you get in exam, you have two options. Okay, one, black sputum can be seen in coal workers pneumoconiosis. Okay, then another one is you can get a black sputum in aspergillus related infections. Okay, it can be an ABPA. Okay, so one should be D, right? Then second, pseudohemoptysis. Where you will get pseudohemoptysis? In Serratia, right? Serratia mascarensis. So you are going to get Serratia associated pseudohemoptysis. Then third, red currant jelly sputum. Where you are going to get red currant jelly sputum? Yes, you're going to get in Klebsiella. Okay, sputum cruntum. What is sputum cruntum? What is sputum cruntum? It might be a new term to you. Sputum cruntum is, it is a blood-stained sputum. Okay, it's a blood-stained sputum. So blood-stained sputum, blood-stained sputum. Where you are going to get hemoptysis? Where you are going to get hemoptysis? Bronchiectasis. So it is. Okay, so these are the options given here. So how many of you have done it correctly? We will see how many of you have done it correctly. So most of you have done correctly. So very good that you diagnosed it properly. Okay, it's I'm very happy that you people diagnosed it very happily. Sometimes what happens is they can ask like this also. Okay, so they can ask like this. Okay, what is this? What you see here? What you see here? Can you observe something here? This is black, right? This black color indicates the patient had a black sputum. Okay, then next is, what is this? This is a pseudohemoptysis. Okay, seen in Serratia. What is this? The third picture. It is a red currant jelly sputum. What is this one? A three-layered sputum which is blood stained here. So it is called a sputum correntum. Okay, sputum correntum. Okay, so these are the different kind of sputums you will get in a patient. Okay, so here again this tabular column tells that whenever you have a serous sputum, it means that it is a watery kind of sputum. Okay, when it is pink and frothy, then it is going to be an acute pulmonary edema. Okay, then it can be due to alveolar cell carcinoma, where we are going to have bronchoria, right? And you can get a mucoid sputum. Where you can get mucoid sputum? Whenever there is an inflammation in the airway, which produces mucus sputum. Okay, purulent sputum. So we all know that yellow color means it is a purulent sputum. Green color means it is going to be a pseudomonas infection. Okay, and rusty sputum is in streptococcus pneumonia infection. Okay, streptococcal pneumonia infection. Okay, so this is about the types of sputum. Okay, again, this tells about the type of sputum. Third question. A 14-year-old boy was admitted in hospital for chronic persistent cough. Okay, he has recurrent episodes of bronchitis since his UKG, kindergarten, and he also gives a history of loose stools, greasy and foul smelling. Okay, his parents are cattle and milk farmers. His brothers are normal. He appears short-statured and weighs 50 kg. Loss of nail angle is noted. So what should be the diagnosis here? What should be the diagnosis here? It is a case of cystic fibrosis. So what made you to think it's a case of cystic fibrosis? What made you to think that this is a case of cystic fibrosis? So this patient has recurrent childhood infection. Okay, recurrent childhood infection. Whenever there is a recurrent childhood infection, along with that, features of malabsorption, okay, then the patient is having clubbing, and changes of bronchiectasis, a young boy coming with bronchiectatic changes, okay. So what you will think? What you will think when a young patient comes with bronchiectatic changes with these things, then you have to think about cystic fibrosis. So this is a case of cystic fibrosis. Very good. So how you people have performed here? If you see here, most of you have performed very nicely and you have taken the correct option. Okay, you have taken the correct option. So even though this concept of cystic fibrosis as a theory, you can see here based on the clinical features, they can frame questions like this. Okay, so what is this Bridges-Good syndrome? What is this Bridges-Good syndrome? Anyone can tell me what is this Bridges-Good syndrome? What is this Bridges-Good syndrome? What is this option A? Very good. It's a case of chronic granulomatous disease. Chronic granulomatous disease. Okay. So it's a case of chronic granulomatous disease, which is called as Bridges-Good syndrome. It is also called as Q syndrome. Okay, Q syndrome. Okay. So here, what is the problem here? There is going to be defective reactive oxygen species formation, so that the phagocytosis is affected. Okay, phagocytosis is affected. And one question in previous years they have asked us nitro blue tetrazolium test. Okay, nitro blue tetrazolium test reduction test has been asked in previous year exams. Okay, in previous year exams it has been asked. So this is one you have to remember. Okay, so what is happens here? There is going to be a color change. That color change has to be appreciated. Okay, so the color change, if not present, there will be a color change to blue color. If that blue color is not present, then it means that there is lack of reactive oxygen species formation. So there is no phagocytosis happening. Okay, there is no phagocytosis happening. Okay, so this is about the chronic granulomatous diseases. And you know what is the most common mutation in a patient with cystic fibrosis? What is the most common mutation in case of cystic fibrosis? It is going to be delta phenotate mutation. Okay, delta phenotate mutation is going to be the most common mutation. Okay, and here what happens here? Here there are problem in regulation of the CFTR. So that is the most common type, and there is going to be problem in regulation of CFTR. Okay, what is the chromosome number? Chromosome number 7. Very good. So this is one, again, an important question asked several times in your exam. Okay, in your exam. So the next question. Next question. So what is the answer here? It is asbestosis, right? Asbestosis. Very good. Oh, very good. So what made you to think that this is a case of asbestosis? What made you people to think that this is a case of asbestosis? Yes. So you people are super good in analyzing questions. Actually, you people are super good. Yes, you people are super good in analyzing the question. So it's a elderly or a middle-aged male marine engineer. Okay, presents with shortness of breath on exertion. So what this line tells, whenever a patient has breathing difficulty on exertion, what you are going to think now? It is going to be something related to interstitial lung disease. And what happens here? The patient has a inspiratory crackles and X-ray is shown like this. Okay, so this X-ray shows what is this pattern called? Someone correctly told it is a holy leaf pattern. Okay, what this Okay, so I will come to that. I will come to that, Sanjeev. Okay, so what is this indicates? This indicates pleural plaques. Okay, pleural plaques. Okay, so this indicates pleural plaques. Okay, so pleural plaques. What is pleural plaques presence indicates? What is this pleural plaques indicates? Pleural plaques indicates there is an exposure to asbestos. Okay, it indicates that is an exposure to asbestos. Okay, so this irregular picture if you get, then think about asbestosis. Okay, so what is the most common pulmonary manifestation of asbestosis? What is the most common pulmonary manifestation of asbestosis? It's going to be a benign asbestos associated pleural effusion. That is going to be the most common manifestation of pleural effusion in a patient with asbestosis. So that is one we used to get commonly. What is another characteristic feature I told you will get in a patient with asbestosis? Anything related to pleura? Anything related to pleura? Yeah, pleura, you most consistent one or the most specific one is going to be mesothelioma. Other than mesothelioma, anything related to pleura and just above the pleura? Yeah, if you remember, I have told that there is something called round atelectasis, right? Round atelectasis. So round atelectasis is one important finding you should never miss whenever questions is asked on the asbestos. So you can see here, this is a round atelectasis. Okay, round atelectasis. You can see here round atelectasis, which is going to give what appearance? It is going to give comet tail appearance. Okay, it is going to give a comet tail appearance. Okay, comet tail appearance. Okay, so hope I'm clear, right? I'm clear. Okay, so how many of you have done here correctly? So again, most of you have done it very nicely. Okay, most of you have done it very nicely. Okay, so the next question we discussed in quizzes, this one. So what is your answer here? So you tell me the diagnosis and tell me the answer. So this is a case of yellow nail syndrome associated with bronchiectasis, right? So this is a case of yellow nail syndrome. Okay, yellow nail syndrome associated with bronchiectasis. So if you see here, you people have again done a wonderful job with this question. Okay, so this is a case of yellow nail syndrome associated with bronchiectasis. So yellow nail syndrome is a primary lymphedema associated yellow nails with pleural effusion. Yes, so you know this. Okay, what happens here? There is going to be underdevelopment of the lymphatic vessels. Because of that, the patient is going to have a lymphedema. Along with that, the patient is going to have a bronchiectasis with the features of pleural effusion and yellow nails. Okay, they are yellow dystrophic nails. Okay, yellow dystrophic nails. Okay, so what are the types of bronchiectasis? You know, types of bronchiectasis. It's going to be a cylindrical type or a varicose type or a cystic type. Okay, which is the most common one? Which is going to be a cylindrical type. Okay, cylindrical type is the most common type, right? Okay, what is this William Campbell syndrome? William Campbell syndrome, absence of cartilage, right? What is this Mounier-Kuhn syndrome? Mounier-Kuhn syndrome, tracheobronchiomegaly. Okay, tracheobronchiomegaly. Okay, so again, I want to say here the questions are asked again from Harrison. Okay, Harrison, you can see here in Harrison, it is clearly given. Okay, clearly given yellow nail syndrome is associated with bronchiectasis, right? And hypogammaglobulinemia is associated with bronchiectasis. Okay, so again, this is very, very important table from Harrison. Okay, this table is going to be very, very important one from your Harrison. Okay, so we'll go to the next question. A 65-year-old female with fatigue, weight loss over last 3 months, sore throat, cough, with a blood-stained sputum, smoker, known case of tuberculosis. Aspergillus fumigatus precipitin positive, and chest X-ray showed a solid lesion at the right lung apex. So, what made you to think the answer? So, if you see our students, so here 127 people have told that it is a case of aspergilloma. Yes, aspergilloma. Very good. It's a very good thought. Okay. So why it is very good is you people have correctly made the option. The reason is whenever you have a chronic condition, then you think about if there is a history of tuberculosis, then the cavity will be occupied by the fungal ball, which is going to be called as aspergilloma. Aspergilloma. Yes. Yes. Okay. Yes. It is RAST is again sensitivity test. Okay. So allergy sensitivity test. Okay. Radioallergen immunosorbent assay. Okay. So when we discussed our asthma, we discussed about RAST, if you remember. Okay, I told how to see for the IgE levels and all, right? If you remember properly in asthma class, I told you how to check for the IgE levels when it is significant and all we discussed. Okay, so this is a case of what? Aspergilloma. Okay, aspergilloma. So any chronic case, you think about aspergilloma. Okay, so this is what the patient was having. This is your patient. This patient had a pre-existing fungal ball, and over the fungal ball, the patient is going to have a cavity with a mass like this. This mass is a fungal ball. Fungal ball. Okay, so this is about the aspergilloma. Okay, aspergilloma. There is no, we didn't invasive aspergillosis. The patient will be immunocompromised. Okay, immunocompromised, and the patient will have lot of previous histories of treatment or something like a solid tumor or something like a radiotherapy or something like a chemotherapy, which the patient underwent, and followed by the patient had a worsening condition going to be invasive aspergillosis. Okay, invasive aspergillosis. It will be a rapidly progressive worsening of the patient, that is going to be invasive aspergillosis. Okay, invasive aspergillosis. And what sign you will get in an invasive aspergillosis? X-ray finding or CT finding? We discussed, right? We discussed what is the CT finding. Very good. We get a halo sign. Okay, halo sign. We get something like this. Something like this, right? Halo sign. Okay, so we get a halo sign. Okay, halo sign. Very good. Okay, ground glass opacities around the nodules will be seen. Ground glass opacities, nodules will be seen. Voriconazole prophylaxis predisposed to mucormycosis. Again, it causes an immunosuppression state where again it can lead to mucormycosis. Any unrequired antibiotics to a patient is again going to be a dangerous thing. Okay, so it is going to again cause immunocompromised state, and patient is going to be prone for fungal infection. Reactivation of tuberculosis. Whenever you have a reactivation of tuberculosis or secondary tuberculosis, what clinical features patient is going to have? The patient is going to have the typical clinical features of fever, cough, and it is nothing to do with again here in this question you can see here Aspergillus fumigatus precipitans is positive, right? So it is not required in a patient with reactivation of tuberculosis. So again, that rules out the option. Okay, that rules out the option. Yes. Yes. So we will go into the next question. So this is again a table from for the previous question. This is a table from Harrison. So the Harrison says that whenever you have a chronic aspergillosis, okay, or aspergillus infection, what is going to happen? The patient is going to have a real-time PCR with antigen positive, okay, and the patient blood diagnostics will be positive for IgG and IgE antibody, okay. So again, this is very, very important for diagnosis, okay, for diagnosis. Next question. So a female patient with ischemic pancreatitis undergoes surgery. On day 3, she develops shortness of breath, worsening, and saturation drop. And chest X-ray shows bilateral alveolar infiltrate with no signs of fluid overload. And what is your diagnosis first? Your diagnosis is ARDS. Okay, very good. A patient post-operative or because of ischemic pancreatitis, the patient later developed ARDS. Okay, ARDS. So this is a case of ARDS. Okay. So in this question, if you see here, only few have told that it is a glucocorticoids. Okay. Many have gone for this option. Okay. We'll see why it is not the correct option. Okay. So again, we have discussed this in our regular class. If you remember, okay, we have discussed in our regular class. Okay. What is the most common cause of ARDS? This is from Harrison table. What is the most common cause of ARDS? It is going to be sepsis. Okay. And ARDS can be due to a direct lung injury or an indirect lung injury. Okay. So you are going to divide ARDS like this. Okay. What is the criteria for ARDS? If you remember correctly, it is going to be a Berlin's criteria. And Berlin's criteria, I told that it is going to be ARDS, acute onset, less than 1 week duration, ratio. What ratio you are going to see? PaO2 by FiO2 ratio, and D for diffuse infiltration in chest X-ray, and S for you put a Swan-Ganz catheter and you check for a PCWP, and it is less than okay. So there is no left atrial hypertension. Okay. So this is what we look for in a patient with ARDS, right? ARDS. Okay. So if you take Harrison, there is one important tabular column which I showed in class also. Okay. Glucocorticoid therapy and surfactant replacement or recommendations D, which means that they are not useful in patients with ARDS. I told you, even though it was very useful when we tried to save the COVID patients, but according to Harrison, in ARDS patient, it is not of much use based on lot of trials. Okay, lot of trials. So I told you, low tidal volume is very important one. At what tidal volume you will keep a patient in ARDS with? What is the tidal volume which you will advise? It is going to be 4 to 6 ml per kg. Okay, and you will start with a high PEEP. Then what will happen to the PEEP? You will start with a high PEEP and you will start reducing the PEEP. What is the target PEEP you want to achieve? Yeah, it should be less than 10. Okay, prone position, and what is this prone position is going to help in? It is going to help in recruitment maneuvers. Okay, it's a kind of recruitment maneuver. It will recruit the alveoli. Okay, alveoli. Then you can go for HFOV, and early neuromuscular blockade is very important one, because you have to give rest to the lung. Okay, if you are not giving rest to the lung, then because of breathing there will be further worsening of the patient. So you have to give for the respiratory muscles rest. Okay, so this is again very, very, very important thing which you have to know. Okay, you have to know. Okay, we'll go into the next question. The 30-year-old RTA victim was intubated and treatment was started. And after 8 days, he developed features suggesting of pneumonia. His condition is attributable to which of the following microorganisms? He was with RTA, he was intubated. Okay, so how we are going to justify your answer? Okay, so how we are going to divide? What is this actually? What is this patient is having? He's having ventilator associated pneumonia. Very good. What is ventilator associated pneumonia? Prakalya, what is ventilator associated pneumonia? When you are going to say a person is having ventilator associated pneumonia, when he will develop pneumonia? Very good, excellent. 48 hours to 72 hours after intubation, the patient is going to develop ventilator associated pneumonia. You can divide ventilator associated pneumonia into two types. One can be an early ventilator associated pneumonia, which occurs within first 5 days, and late onset VAP, which is going to be after 5 days. Okay, after 5 days. Okay, and here it is might be due to a Staphylococcus, strep pneumonia, okay, Klebsiella, or other gram-negative organisms, and Haemophilus influenza. Okay, early onset VAP. Okay, we have late onset VAP, which occurs after 5 days of intubation, and it can be due to Pseudomonas aeruginosa, MRSA, Acinetobacter, Enterobacter, or vancomycin resistant Enterococcus. This we have already seen in our class. Okay, and this answer is going to be Acinetobacter species. Acinetobacter species. Okay, so how many of you have done it correctly? We'll see how many of you have done it correctly. So most of you have gone for this one, right? And equal proportion of people have gone for Streptococcus also. Okay, when it is less than 5 days, then this option is correct. But after 5 days, okay, post intubation, after 5 days, it is going to be Acinetobacter. Okay, Acinetobacter, and all these options come under less than 5 days. Okay, early onset VAP. Hope I'm clear about this. Clear, right? Yes. Shall I go to the next question? Okay. So on the basis of tuberculosis infectivity, arrange the patient with maximum and minimum chance if the patient has these manifestations. So the question meant here is, which of the following lesion is having more infectivity chance? More infectivity chance. Which is the most infectious tuberculous lesion? I told you it is going to be cavity. So it is 2, right? So we are left with B and D. Okay. Then second most common, what I told in our regular class. It is going to be after cavity, what I told. Endobronchial or laryngeal TB, I told. Right? Endobronchial TB. Okay. Then it is going to be sputum AFB positive or culture positive patients. Then it is going to be MAN2 positive, culture negative patients. So it indicates they have a latent tuberculosis. So the correct option here is going to be B, right? B. Yes. So how many of you have done it properly? So many have selected option B, but equal number of people have gone for A also. Okay. So why you have gone for A? So the most infectious, again, I have told this, I emphasize this in the class, right? Emphasized in this class, if you remember this correctly. Okay. So this is a patient, the most common mode of spread of tuberculosis is going, this again from Harrison. See, most of 99% of our references is going to be Harrison, and most of the times, or 99% of the time, you will get your answer in Harrison. Okay. For your level, Harrison is going to be more than enough, I feel, because most of the time you will get the answer from Harrison. Okay. So that's very, very important, because so you should know how to approach the theory part and how to interpret a question which is asked in exam based on your theory knowledge. That is very, very important. Okay, so this is expressed by droplet nuclei. Okay, again and again in our regular class, I have emphasized how to approach the questions based on the theory knowledge you have and based on what you read from whatever source available. Okay, so this is very, very important. So it spreads by droplet nuclei, right? Droplet nuclei. And again, if you see the Harrison clearly mentions this. Okay, so the most infectious patients are cavitary pulmonary tuberculosis patient. Okay, the most infectious are cavitary pulmonary tuberculosis, followed by laryngeal TB or endobronchial TB. Okay, patients with sputum smear negative and culture negative or culture positive even are less infectious. Okay, less infectious. So the most common is going to be cavity. Okay, and culture negative pulmonary tuberculosis and extrapulmonary tuberculosis are essentially non-infectious. Okay, non-infectious. Okay, whether a HIV patient will have cavity, the newly diagnosed HIV patient with tuberculosis, whether he will have cavity? No. Why? Why? How he will behave? He will behave like a what kind of patient? He is immunocompromised, so he will behave like a primary tuberculosis patient. Okay, he will behave like a primary tuberculosis patient, right? Primary tuberculosis patient. Very good. He will behave like a primary progressive tuberculosis patient. Very good, Tanuja. Very good. Excellent. Very good. Okay, so we'll go into the next question. Okay, I'm very happy that you people are able to crack the questions very nicely. Okay, so your way of approach is again very good. A 45-year-old woman presents to casualty with 5 days history of low-grade fever, shortness of breath on exertion, and non-productive cough. Heart rate is 96, saturation is 96, X-ray is normal. Which of the following tests would help to rule out pulmonary embolism? So rule out means what test you are going to do. When you want to rule out something, what test you are going to do? You are going to go for a screening test. Okay. What is your diagnosis here? Your diagnosis, or what is your suspicion? What you suspect? You suspect a pulmonary embolism. What is the screening test in pulmonary embolism? D-dimer. Excellent. Okay. So excellent. How many of you have done it correctly? So if you see here, so many have gone for D-dimer, and more than that, people have gone for pulmonary angiogram, right? Pulmonary angiogram. Okay. I will tell you why it is not pulmonary angiogram. Okay. Pulmonary angiogram. Whenever you suspect a patient, okay, with pulmonary embolism, what is the first thing you will do? My buddies who attended the class, what is the first thing? Very good, Raksana. Very good. The first thing what you will go for is you will go for well score. Okay. When well score is less than 4, more than 4, you have to see. Okay, whether it is a low probability or a high probability. Okay, so when it is a low probability, then what you're going to do? You're going to go for D-dimer. Okay, if D-dimer is positive, then you go for what? CT angio. When it is more than 4, then directly you can go for CT angio. Whether our patient here comes under low probability or high probability. So what is the well score? I told you how to check for the well score. How to check for the well score? Clipham TDS. Very good. Excellent. Okay. So it is clinical signs of DVT. Okay. No alternative diagnosis you have. Okay. And tachycardia is there. Okay. And DVT is the only previous history of DVT. Okay. any surgery or any immobilization in the past, okay, hemoptysis and active malignancy is present. Okay, so you first check for this. Okay, after checking for this, you will go for this chart. Okay, this chart tells what you were telling. Okay, first assess the patient, then go for D-dimer, then go for CT angio, then plan for treatment. Okay, then plan for treatment. Again, if there is a high probability that is more than 4, then go for CT angio directly. Okay, CT angio directly. Excellent, guys. Excellent. You are doing an excellent job here. Okay, so what is the treatment you will go for in a patient with pulmonary embolism? It is a small emboli, no vascular compromise, no right ventricle involvement. That is, there is no right ventricular hypokinesia or akinesia. So what you will do? You'll go for a anticoagulation. Okay, anticoagulation, right? Yes, very good. When there is a submassive or a massive emboli, submassive or massive emboli, you'll go for thrombolysis. If there is any contraindication for thrombolysis and it is an acute condition, then what you will do? You will go for embolectomy. When it is a chronic condition, then you will go for and it is not getting controlled with anticoagulants, and then there is a recurrent embolization, then what you're going to do is you're going to go for a IVC filter. Okay, IVC filter. Okay, so hope I'm clear about this. Okay, we have discussed this enough. And again, the same thing from Harrison here. Okay, Harrison here. Harrison says everything. Pulmonary embolism suspicion, probability, you have to check, D-dimer, then you go for CT angio. Okay, CT angio. This is from, again, Harrison. Okay, Harrison. And this is also from Harrison. Okay, a normal D-dimer is useful to rule out the disease. Okay, the normal D-dimer is useful to rule out the disease. Okay, disease. Very, very important thing which you have to remember. Okay, next one. The following statements are true regarding pneumothorax, except which one? Except which one? You have selected option A, right? Okay. So what you people have done here? Only few people have gone for option A, and many have gone for option C. Okay. So we will see what happens in pneumothorax. Okay, pneumothorax. Okay. So this is the lung. And if you see the intrapleural pressure, normally it is going to be subatmospheric. Normally it is going to be subatmospheric because the atmospheric pressure is considered as 0. Okay, 0. Now you have an opening here. Okay, now when you have an opening here, this passage is going to be continuous with the atmosphere. When it is continuous with the atmosphere, what will happen to the intrapleural pressure? It will also becomes equal to atmospheric pressure. So it is going to be 0 in pneumothorax. Okay, equal in pneumothorax. Okay, so this option is a wrong option. The tension pneumothorax produces mediational shift with hemodynamic compromise. Yes, so only it is called as a tension pneumothorax. Then tube thoracostomy and suction followed by water seal drainage is not required for all patients. It's not required for all patients. So it is correct. Pneumothorax may occur spontaneously in individuals without a history of pre-existing lung disease. What it is called as? What you call it as? What you call it as? It is called as spontaneous primary pneumothorax. In which people you will suspect? What history will be given in your question? It is because of pleural blebs. Excel and Aishwarya. tall smoking individuals. Okay, tall smoking individuals. Very good, excellent. Okay, so this is very important because the intrapleural pressure is 0 during pneumothorax. Okay, pneumothorax, very important thing. Okay, it equals 0. Okay, so this is very important. Okay, so whenever you have a tension pneumothorax, it is going to cause a mediastinal shift, right? Mediastinal shift. Very good, mediastinal shift. Okay, what are the indications for chest drain insertion? We have already seen this. Okay, chest drain insertion is required whenever a patient is having a tension pneumothorax, a recurrent pneumothorax, secondary large pneumothorax. Okay, whenever the patient has a pre-existing disease or any ventilated patient, again you need a chest drain insertion. Okay, chest drain insertion. Very important point. Okay, very important point. And one more thing I told you that tension pneumothorax requires tube insertion, then recurrent pneumothorax requires tube insertion, and large, that is more than 2 centimeter, then it is going to be requiring a tube insertion. And this is several times I have emphasized in the class. Okay, a patient admitted with pneumonia and a large pleural effusion, which are the following feature is most consistent with the presence of complicated parapneumonic effusion? You are selecting option as B. Okay, B. Okay, so I told you about 2 effusions. One is going to be a pneumonic effusion, another one is going to be a how to differentiate types of pneumothorax based on what you want. So if we are having 3 types of pneumothorax, if you remember, if you attended the class, you would have known that open, closed, and tension pneumothorax. Okay, tension pneumothorax, right? So where is in open pneumothorax? Where is the problem in open pneumothorax? I told you it's a chest wall problem, like a gunshot injury, where air goes inside, air comes outside. Okay, then closed pneumothorax. Here it is going to be in the lung, okay, or in the visceral pleura. So there is a rent like in a newborn. Okay, what is going to happen here? The air goes like this and comes out like this. Whenever there is a tension pneumothorax, what is going to happen? It acts like a one-sided wall. It can be inside or outside, but it acts like a one-sided wall. So what is going to happen? It is going to be like this. It is going to be like this. Okay, during inspiration it opens, air comes inside. During expiration it closes. During inspiration it opens. During expiration it closes. Okay, so this is going to be the feature of tension pneumothorax, where the patient is going to have. If it is a tension pneumothorax, how you are going to see? Whenever you suspect a simple open pneumothorax or a closed pneumothorax, what is going to happen? The patient will have breathlessness, sudden onset, and he comes to you. Whenever there is a tension pneumothorax, it's a respiratory emergency or a pulmonary emergency, where the air in the pleural cavity is going to push the mediastinum. When it pushes the mediastinum, what is going to happen? The heart is getting pushed. When heart is getting pushed, what is going to happen to the aorta? The aorta getting compressed, and because of that, the patient is going to get hypotension. And what is going to happen? In JVP, it is the jugular vein is going to get compressed. So there is going to be a non-pulsatile venous engorgement can be present. Okay, and when you auscultate, what will happen to the breath sound? Breath sounds will be absent. Okay, with breath sounds will be absent. And what will happen to the trachea? Trachea will be shifted to the opposite side. And what will happen to the apical impulse? Apical impulse will be shifted further laterally. Okay, so this will tell that the patient is having a tension pneumothorax. Okay, tension pneumothorax. Again, coming to our question here. So this is we already saw that we have a pneumonic effusion and a parapneumonic effusion. Pneumonic effusion, pneumonia with effusion. Parapneumonic effusion is pneumonia followed by effusion. Okay, effusion. So whenever you think about a complicated pleural effusion, okay, complicated pleural effusion, our Harrison says that a patient has having a complicated pleural effusion, okay, and he requires thoracocentesis, okay, when a patient has a pleural fluid pH of less than 7.20 or a glucose less than 60 or a positive gram stain or culture pleural fluid. Okay, when you do a pleural fluid gram stain, it is positive or culture positive, or there is a gross pus in the pleural space. Okay, then it is going to be a complicated pleural effusion, and these patients with complicated pleural effusions require tube drainage. And one more indication for tube drainage is more than 1 centimeter. So how we are going to calculate whether it is more than 1 centimeter, less than 1 centimeter? How you are going to calculate? I told you, you take a lateral X-ray, okay, from the chest wall to the visceral pleura, you calculate the distance. When it is more than 1 centimeter, then it is going to be requiring tube drainage, okay, tube thoracostomy. Okay, this is another one. Tabular column tells that whenever a patient has complicated pleural effusion, then the pleural fluid is going to be turbid, pH is going to be less than 7.20, glucose will be less than 40 to 60, LDH will be more, leukocytes will be present, culture will be present. Okay, culture will be positive for. So this is one important thing which you have to remember. Okay, remember. So this picture also tells the same. Okay, as the color of the pleural fluid changes, and it is going to become more complicated. Okay, more complicated. And pH of less than 7.20 and glucose less than 60, you should never forget. Okay, and whenever an organism is present, either in smear or culture, then it is going to be significant. Okay, significant. Okay, so hope I'm clear with this. Okay, so what happened? How many of you have done it correctly? Only 62 people have done it correctly. Okay, and most of you have gone for this. Okay, so it is going to be a complicated pleural effusion, which is going to be less than 7.2. Okay, so next question is, cigarette smoking is not a known risk factor for. So here people are selecting for option D. So we will see how people have responded here. Cigarette smoking is known to be a risk factor for all except. Okay, so most of you have gone for this one. Okay, but almost equal number of people have gone for this one also. Okay, so you remember in our class I have told you. Okay, and apart from class, even Harrison has tells the same thing. Okay, Harrison tells same thing. Okay, whenever you think about smoking related ILD, okay, smoking related ILD, you have to think about respiratory bronchiolitis associated ILD. The second one is going to be DIP. The third one is going to be PLCH. What is PLCH? Pulmonary Langerhans histiocytosis. So this I told you in the class also, right? Class also. Which condition where smoking is going to increase the complication associated with ILD? Smoking is going to be a risk factor, or it is going to complicate the ILD. I told you, if you remember, which has bad prognosis and it is going to complicate further with smoking. You remember? It is going to be a usual interstitial pneumonia. Okay, usual interstitial pneumonia. Correct, Salman. I have told this in the class also. Okay, so this is very, very important. This is very, very important. This is what Harrison also says. This is from this page is from Harrison only. Okay, this page is from Harrison. Harrison says that. Okay, so most of your questions you will have your answer in Harrison. It is how you pick up the points and how you are going to use it in your exam. That is very, very important. That is what we try to do regularly in our class, and we try to interpret how to make these questions, these theory part as a good answer or a good clinical diagnosis. Okay, so same thing is given here. Respiratory ILD, DIP, PLCH. Okay, PLCH. Okay, so the same thing here. Okay, what macrophages I told you we will get in smoker associated interstitial lung disease, copper penny bodies, or what macrophages we get? Smokers, macrophages we will get. Okay, so it is pigment laden macrophages. Pigment laden macrophages you will get, right? So this is very, very important for you to know. Okay, for you to know. Okay, next question. Which of the following is best characterized radiographically as an alveolar filling disorder? So many have taken option C, which is an acute interstitial pneumonitis. Okay. So, you know, um, you know, what is the disease which acute interstitial pneumonitis resembles? It resembles ARDS, I told you. So it is one kind of ILD which is going to be acute, and there is going to be a diffuse alveolar damage. I told you in our class. Yes, Dr. Maheshwari, very, very correctly as you said. Okay, so this is from Harrison again. Okay, Harrison says that there is AAP is a rare and acute form of ILD where there is going to be an acute onset respiratory distress and hypoxemia. Okay, and it resembles ARDS. So it is very difficult to differentiate from ARDS. Harrison says this. Okay, and what you're going to get, you're going to get a bilateral ground glass opacities. Okay, and there is going to be diffuse alveolar damage. What is the treatment? Treatment is going to be mechanical ventilation. What I told about the mortality, or how is the prognosis? It has a worst diagnosis, a worst prognosis. I told you, right? Very bad prognosis. 60% mortality. I told you. Okay, 60% mortality chances are there. Okay, so this is how you will differentiate different types of ILD based on X-ray, right? So what will be the finding you will get in UIP? When they give UIP for you, how you are going to diagnose? It is going to be reticular opacities involving both bases, right? Subpleural reticulations and honeycombing will be there. Very good, Dr. Muhammad Salman. And NSIP, what pattern you will get in NSIP? You will get ground glass opacities. Okay. Then what you will get in organizing pneumonia? It has two types, right? What are the two types? Obstructive and constrictive or restrictive type, and you are going to have a atoll sign, right? Atoll sign, very good. And DIP, we saw lip. Which disease lip is associated with? Which disease lip is associated with? Lip means what you should think? Jogrens, very good. Jogrens, very good. Okay. So this you have to think, right? So this is about our interstitial lung disease patterns. Okay. So when we see the analysis here, so many have gone for lymphangioliomatosis. Okay, lymphangioliomatosis. Okay, this is not the answer. Okay, which condition is associated with the LAM? Pulmonary lymphangiomyomatosis. Which condition is associated with LAM? Tuberous sclerosis. Excellent. Tuberous sclerosis. And what is the drug you will give? What is the drug you will give? Dairy milk question. You will get a dairy milk. Very good. Sirolimus. Very good. Very good, Dr. Srinivas. Very good. Very good. Okay. Okay. So this question, a 35-year-old male nagging productive cough is applying for divorce on grounds of infertility. Which diagnostic approach will not be helpful in determining the cause of cystic fibrosis? So here, sweat test, we can go for extended CFTR genotype analysis, we can go, and family history we have to ask for. Okay, so here the option is going to be kidney involvement. Okay, so we'll see why and how Harrison says this. Okay, before that, what people have done, many of you have gone for this correctly. Okay, correctly, and few have gone for this other options. Okay, we'll see why this is very, very important to know. Okay, so whenever you have a cystic fibrosis patient, okay, so you have to, the gold standard thing is going to be CFTR genotyping. Okay, but what is the screening test you do in this patient? Screening test you will do in this patient? Screening test in this patient, you will go for a sweat chloride level of more than 60 is going to be significant. Okay, more than 60 is going to be significant. Okay, what is the confirmatory test? Confirmatory test, it is going to be transmembrane potential difference, elevated transepithelial charge separation. That is what we call it as transmembrane potential difference. What is the gold standard investigation? Gold standard investigation, it is going to be DNA analysis, gene sequencing to be done. Gene sequencing can be done. So I told you there is a criteria for cystic fibrosis diagnosis. Okay, cystic fibrosis clinical features and biochemical findings is the basis of the diagnosis. One, clinical features suggestive of cystic fibrosis, positive neonatal screening for cystic fibrosis, or a positive family history. Out of this, one is required. And biochemical evidence, positive sweat test, positive uh, um, nasal potential difference or transmembrane nasal potential difference, or at least two mutations. I told you here, there is going to be a lot of mutations involving CFTR in different levels, but two mutations. It can be a delta 508 with the delta 551D also. So if it is so, then it is going to be more towards a cystic fibrosis. Okay, it is more towards cystic fibrosis. So this is very, very, very important. Okay, and the sweat chloride test of more than 60 on 2 occasions is required. On 2 occasions is required. Okay, 2 occasions is required. So this is again an important question, important thing. Cystic fibrosis will follow you like anything. So learn about cystic fibrosis very nicely. Okay, follow you like anything. So follow cystic fibrosis like anything. Okay, so this is about the cystic fibrosis related question. So we'll go into the next question. Which of the following gene is associated with central congenital hypoventilation syndrome? So many have gone for B, FOX2B. Okay, FOX2B. What is this central hypoventilation syndrome fondly called as? It is called as, very good, Dr. Jairam. It is called as online curse. Online curse. Okay, what is online curse? Okay, so here, if you remember, FOX2B, which is going to be, sorry, polyalanine repeat expansion mutations form. Okay, this mutation will result in shallow breathing due to this dysregulation of the respiratory drive. Okay, respiratory drive. Okay, so during non-REM sleep, what happens is these patients will have a shallow breathing. Okay, shallow breathing. Okay, and this because of the transcription factor FOX2B is absent. Transcription factor FOX2B is absent. Okay, so these patients will have, along with this online curse, other features like neuroblastoma, okay, or Hirschsprung disease, okay, or dysphagia. Wherever the ganglia is getting involved, those kind of diseases will be associated. Okay, associated. So this patient will have FOX2B mutation. Okay, FOX2B mutation. So how many of you have gone? So many of you have gone for this as a correct option. Okay, so if you would have known this and if you have gone for this answer correctly, then I'm very, very happy about this. Okay, very, very happy about this. Okay, if you have known the question and gone for the question correctly, then I'm very, very happy about it and proud about it. Okay, so CFTR, where it is associated? Very easy one, cystic fibrosis, right? Alpha 1 antitrypsin deficiency, you know, which emphysema? Very good. Pan-acinar emphysema. BMP, pulmonary hypertension. Very good. Excellent. 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 Pulmonary hypertension. Very good, Dr. Priya. Very good. Okay. So pulmonary hypertension. Okay. So the next question. Okay. Next question. Okay. So this also a done and dusted question for you people. Okay. What is this? A reduction in mortality attributable to oxygen therapy has been demonstrated in individuals with COPD and and severe resting hypoxemia less than 88% of saturation. This is what many people have told. Okay. Okay. So what is the indication for long-term oxygen therapy? What is long-term oxygen therapy? What is long-term oxygen therapy? What is long-term oxygen therapy? So more than 15 hours per day, we are going to put a patient on long-term oxygen therapy. Very good. Okay, 15 hours. Okay. So here, how you people have done. So many only few have gone for this and many have gone for this one. So yeah, around 16 hours per day. Okay. So as I told in the class, okay. So this is about Harrison's, what it says. Okay. So a resting oxygen saturation of less than 88% in any patient. Okay. Or I told you one more thing. What is the PaO2 of less than 55 millimeter of mercury, or 89%, less than 89% with the signs of pulmonary hypertension or pedal edema or features suggestive of right heart failure. Okay. So in these patients, the use of oxygen has been demonstrated to have a significant impact on mortality. Okay. So this is a direct pickup from Harrison. See how wonderfully Harrison has given few things which can be framed as questions. Okay, framed as questions. This can be made more clinical also. This question can be made more clinical also. I can make some 10 lines of questions also from this point. Okay, so this is a very, very important point. Okay, so always remember this. Whenever a patient has a saturation of less than 88% or a PaO2 of less than 55, any patient you will go for long-term oxygen therapy, but less than 59 millimeter of mercury and less than 89% of SpO2, you will go whenever the patient has features of cor pulmonale, that is, a patient has chronic hypoxia because of this hematocrit is increasing, patient has right heart failure, pulmonary hypertension features, or patient has a pedal edema. Okay, then you will go for an early long-term oxygen therapy. Long-term oxygen therapy. The very, very, very important thing you have to remember. Okay, remember all patients require long-term oxygen therapy if less than 55 and less than 88%. Okay, less than 88%. Okay, then coming to the next question. A 75-year-old man has confusion Okay. Then what else he has? Right lower lobe pneumonia. Respiratory rate is more than 36. Pulse rate is 90. BP is 106/48. Urea 12 millimoles per liter. So you have selected the option as A. You people have selected now the option as A. You will see how people have responded. So many have gone for option B, which is 3, but the correct option is option A, which is 5. You will see why it is. Okay. So here we are going to have an important score called curve 65 score, which says that CURB 65. Okay. C for confusion. So our patient has confusion or not? Yes. So it is going to be 1. U for urea. Okay. Urea more than 7 millimoles per liter, or it can be more than 20 milligram per deciliter. Okay. So here our patient is having 12. So it is going to be 1. Respiratory rate of more than 30. Our patient has 1. Blood pressure 90/60, less than 90/60. So our patient has either 90 or less than 60. Okay. So here our patient has 1. Age of our patient is more than 65, 74 years. So it is going to be 1. So what should be the total score here? 5. So the answer is 5. Okay, the answer is 5. And here, whenever you have a curve score of 0 to 1, treat the patient in home. When the score is 2, you can admit in ward. Okay, or monitor the patient properly. Okay, when the score is more than 3, then ICU. So remember 1, 2, 3. 1 requires home, 2 requires ward, and 3 requires ICU. Yes, very good. Okay, very good. So this is about the curve 65 score. Okay, next question. The 44-year-old man is on varenicline. What is the mechanism of action of this drug? So again, there is mixed answers here. Okay, so I'll see what many have answered here. So many have answered option D. Okay, and almost equal number of people have answered A also. Okay, so what is this drug? Okay, usually nicotine works through dopamine receptor. Okay, nicotine works through dopamine receptor by a process called reinforcement. Okay, reinforcement. Okay, this reinforcement is one important thing. Okay, which causes addiction, and this dopamine is going to be increased release in the nucleus accumbens. This nucleus accumbens release is going to cause the patient to have more addiction. Okay, more addiction. Okay, so this varenicline acts by blocking alpha 4 beta 2 nicotinic choline acetylcholine. Okay, acetylcholine receptor. Okay, acetylcholine receptor. Okay, thereby it inhibits dopaminergic activation. Okay, this is what happens. So the answer here is going to be option D. Okay, option D. Next question. A migrant worker, fever, painful eye, okay, with saturation of 92% and bilateral swelling of both cheeks. Okay, this is her X-ray. What this X-ray shows? This is a case of excellent, Dr. Bhuwana. This is a case of sarcoidosis. Yes. Okay. And this is an acute sarcoidosis. Okay. And you can see here there is going to be a lymph node enlargement here. Okay. It is going to have a lambda sign or a what sign you will get? Garland sign or 1, 2, 3 sign or Hornbroker sign. Very good. Excellent. Very good. Okay. So this is a case of sarcoidosis and the answer is going to be Hereford syndrome. And as I told you previously, we have two syndromes here. So how people have done? People have done excellently. They have selected this as an option. So we have two syndromes here. Okay. So the first one is going to be Lofgren syndrome. Okay. Lofgren syndrome. What is Lofgren syndrome? What song? Helena will come into play. Okay. So what is Helena? Hilar adenopathy, lymph node enlargement. Next is erythema nodosum and arthritis. More commonly ankle, and it is going to be a symmetrical involvement. Okay. The next is Hereford syndrome. What is Hereford syndrome? Hereford syndrome is poof. Okay. So it is going to be parotitis because of that bilateral patient has enlargement. Okay. Then uveitis, anterior uveitis, because of that only the patient is having a red eye. Okay. Then patient has fever. Along with that, the patient will have facial nerve palsy. Facial nerve palsy. Okay. Facial nerve palsy. Okay. Facial nerve palsy. So this is again very, very important to tell you the diagnosis. Okay. Important to tell you the diagnosis, and our answer is going to be Hereford-Waldenstrom syndrome. Okay. Hereford-Waldenstrom syndrome. Next question. You review a 27-year-old female in casualty who is admitted with acute exacerbation of asthma. Okay. And you are treating her. Which one of the following feature is most likely to indicate a life-threatening attack? Acute severe asthma or a life-threatening asthma? So what people have done here, we'll see. So many have gone for not able to complete sentence, failure to improve with nebulized salbutamol, peak flow of 30% best or predicted. Okay, so these three options more or less equally people have selected. Okay, so whenever you have a acute life-threatening asthma, okay, whenever you have a acute life-threatening asthma, okay, you have to remember few things. One is called, I call it as 32-92 chest. Okay, remember as 33-92 chest. What is 33-92 chest? PFR less than 33%. Okay, Don't think about any other thing. Okay, I mean, in the sense what I tell us, we have 33 to 50, more than 50 and all. Okay, don't think those things. PF less than 33%. Okay, 92 SpO2 less than 92%. Okay, then chest, cyanosis, hypotension, exhaustion, patient is extremely non-responsive or tired, silent chest, and sometimes tachycardia. And I also told you what you will get in patients with acute severe asthma sometimes. What I told you, the patient can get paradoxical bradycardia also. Paradoxical, excellent, Dr. Srinivas. Paradoxical bradycardia also. So you have to remember this, and here several times in your exam they are going to ask this. In your exam they are going to ask this. Okay, ask this. So this is what you will check in a patient with acute severe asthma. Okay, acute severe asthma. So this is a case of acute severe asthma with life-threatening changes are there. Then you have to think about PF of less than 33%. When there is a complete saturation drop, which is not picking up, then patient is going to for failure. Okay, failure. SpO2 less than 92%, silent chest, okay, cyanosis, exhaustion, hypotension, okay. And whenever your PaCO2 keeps increasing, what happens? PaCO2 increasing means you have to tell me how. If PaCO2 is increasing means, then what it means? Patient is switching over to complete airway obstruction leading to type 2 respiratory failure, right? CO2 narcosis. Very good. That you have to think. Okay, that you have to think. Okay, so this is very, very important. You can take a quick of photo of this also. This is very, very important. Okay, very, very important. Okay, very, very important. Yes. Next question. Which one of the following is responsible for farmer's lung? So B. Okay, many have gone for B. Okay. So what here people have told? People also told B, and few have told that answer is A. Okay. So we'll see why this is important. Okay. So again, this is from that table in Harrison. Okay. One important table you have to memorize or remember or try to make some methods to remember whatever you do, but don't forget to remember this tabular column. Very, very important tabular column. Okay. So farmer's lung is the first thing which is given in that Harrison table. You will, if it is given a thermophilic actinomyces, then you can directly go for this answer, right? You would have gone for this. But what they have given is, they have given example Saccharopolyspora rectivirgula. Okay, so answer here is Saccharopolyspora rectivirgula. Very, very important, and we have discussed this in class also. Okay, then KCI. KCI means caseous material, cheese-like material. So I told you cheese versus lung. Then I told that malt workers lung. What is malt worker? Malt workers lung. We're going to get Aspergillus species. Okay, clavatus, right? Clavatus. Very good. Then Miller's lung. Miller's is mill means granary. I told you. Cytophilus granarius. Okay, then what we discussed in our class, winemaker's lung, botrytis cinerea, botrytis cinerea. Then next is bird fanciers lung. Lot of questions we discussed about bird fanciers lung, right? Bird fanciers lung. Then next is chemical workers lung. I told you isocyanates. Okay, hot tub. Hot tub is MAC and cladosporium. Cladosporium. Detergent workers, I told you, Bacillus subtilis. Okay, Bacillus subtilis. Then sauna, Orobasidium. Okay, sauna means Orobasidium. So lot of times this both can be together. Okay, sauna takers lung or hot tub lung. Okay, then these are the important things. Okay, these are the important things for your exam. Okay, so remember this, very important for your exam. Okay, so as you responded, it is going to be Sacropolyspora rectivirgula. Okay, lot of time this is going to be an important point to remember in your exam. Okay, so you please remember this point. This is going to be very important for your exam. Okay, then next question. Next question. So he wants to do Guinness record and he wants to continue his Guinness record by climbing Himalayas. Okay, Himalayas. So what you are going to plan for? What you are going to advise him? You're going to plan for a carbonic anhydrase inhibitor, okay, which is going to be our acetazolamide. Okay, you are going to plan for acetazolamide. And how people have answered? So many have answered correctly. Okay, many have answered correctly. Okay, very happy for that. So whenever you travel, okay, it depends upon the altitude. Okay, it depends upon the altitude. And as you cross certain altitudes, what is going to happen is there are going to be certain changes happening in our body. Okay, the first one which happens is going to be acute mountain sickness. Okay, acute mountain sickness. Acute mountain sickness. Okay, so what is acute mountain sickness? Okay, so a person travels, okay, to a mountain. Okay, and after 6 to 12 hours of reaching that place, the patient is going to develop symptoms which are going to last for 24 hours around. Okay, why this happens? Okay, whenever they reach this place, fast ascent. Okay, whenever they reach a height which is going to be somewhere around more than 8,000 feet or 2,500 meter. Okay, and people who with history of altitude sickness. Okay, why this happens? When you reach at a high level, at higher altitude, there is going to be decrease in partial pressure of oxygen, and there is going to be decrease in partial pressure of gases, which is going to cause a decrease in saturation. Okay, so the inspired oxygen partial pressure is going to be decreased. Okay, and this is going to cause certain changes in the body. Okay, so what is going to happen? This hyperbaric oxygen, is going to cause tachypnea, and there is going to be respiratory alkalosis because CO2 gets washed out. Okay, and this causes increased glycolysis. Okay, this glycolysis increases 2,3 BPG. Whenever there is an increase in 2, BPG, what will happen to the oxygen curve, oxygen dissociation curve, where it will shift? Increase in 2,3 BPG. Shift to right. Excellent. Shift to right. What is this effect called as? Shift to right means increased oxygenation of tissue. So there is going to be Bohr effect. So shift to right is going to happen, and there is going to be increased oxygenation of tissues. Okay, and this also enhances sickling of cells, sickling of RBC, which is going to cause a lot of changes in the body. Okay, lot of changes in the body, and this polycythemia, this relative hypoxia, which occurs when you go to higher altitude, will also result in polycythemia. Because of hypoxia, there is going to be polycythemia, and this is also going to cause sickling of RBCs. Okay, and ultimately the patient is going to develop pulmonary hypertension. Pulmonary hypertension. Pulmonary hypertension. Okay, hypertension. And what is the most common symptom what the patient will tell to you apart from breathing difficulty? What is the most common symptom the patient is going to tell you apart from what to say, breathing difficulty? It is going to be headache. Okay, so many of you would have felt that, right? When you go to somewhere like Ooty, Kodaikanal, Shimla, on reaching after some time, you will start developing headache or you will feel very sleepy. Okay, so patient develops headache, fatigue, dizziness. Okay, so how to prevent this? Okay, how to prevent this? So whenever patients are symptomatic, you can try NSAIDs on reaching the place. On symptomatic treatment is NSAIDs. Okay, and you can give acetazolamide. Okay, if they ask you drug of choice, then it is going to be acetazolamide. This acetazolamide is going to be both used as treatment and used for prophylaxis. Okay, prophylaxis. So this is very, very important, very, very important. Okay, and you can also use dexamethasone for prophylaxis. Dexamethasone for prophylaxis. Dexamethasone for prophylaxis. Okay, so drug of choice is going to be acetazolamide. Apart from this, you are going to have two things, very important complication as you reach at a higher level like this. Okay, as you reach at this level or at this level, what is going to happen is you are going to develop two things. One is called haze, another one is called HAPE. Okay, what is haze and HAPE? Haze is cerebral high altitude associated cerebral edema. Another one is called as high altitude associated pulmonary edema. Okay, this is again occurs when you go for a rapid ascent. Okay, rapid ascent. Okay, that is called haze and HAPE, and there is a differential diagram. I mean, I have put a tabular column like this. Okay, as you reach higher altitudes, what is going to happen? The patient is going to have haze and HAPE. Okay, haze and HAPE. Very, very important. A very, very important thing you have to know. Okay, you have to know. Right? Then next question. The patient on antibiotics for UTI and renal calculi. Over the last 3 days, he developed a cough, productive sputum, and tiredness. He is alcoholic and addiction history is there. Bilateral cavitating opacities are seen in the upper lobe. What is the answer? So many have gone for Klebsiella pneumoniae, right? Klebsiella pneumoniae. So how you have responded in the exam? Again, you have responded as Klebsiella pneumoniae. So what made you to think about Klebsiella pneumoniae? What made you to think about Klebsiella pneumoniae? So alcoholic with UTI. So both things have made you to think that it is a case of a Klebsiella. Yes, exactly. That is a clue here. and one more could be cavitating lesions. Okay, cavitating lesions. So whenever you have a patient with pneumonia, okay, and they give a X-ray like this, okay, you have two things like this, okay. So you can see a cavity here, okay, and there is going to be a fluid-filled cavity. You can see a water level here. So this can be indicating that the patient is having Klebsiella pneumonia. And one more thing is you get a thickened pleura like this. Okay, that is the sign called as bulging fissure sign. These two things can tell that the patient is having a Klebsiella pneumoniae. Klebsiella pneumoniae. So this is again a cavity with a bulging fissure. Okay, cavity with a bulging fissure. This is called as bulging fissure sign. Bulging fissure sign. Okay, and what is this? What is this? This is a small boy or a young boy. These are called nematocele. Okay, nematocele, thin-walled cavity. Okay, thin-walled cavities in patients with Staph aureus infection. Okay, Staph aureus infection, and this is a case of a lobar pneumonia. Okay, so more towards Klebsiella pneumoniae. Okay, Klebsiella pneumoniae. I'm based on the options I gave. I'm asking. Okay, based on the options I gave. I'm asking. Okay, and sometimes patchy pneumonitis you can get. Okay, patchy pneumonitis you can get. And what is this indicates? What is this? Again, a young boy, a small boy, a new young fellow around 3 years or 4 years, for example, coming with pneumonia. This is called as round pneumonia. What is round pneumonia? Where you will get round pneumonia? Round pneumonia, strep pneumoniae. Okay, it is because of the poor development of pores of Kohn and canals of Lambert. You are going to get localized collection, which is going to be called as round pneumonia. Okay, round pneumonia seen in children. Okay, because these canals are absent in children's. Because of that, it is confined to a single area. So it is called as round pneumonia. Round pneumonia. Okay, what is this again? This is looks like a atypical pneumonia. You cannot define which area is getting involved, and lot of small interstitial spaces are getting involved here. So this is a case of Legionella pneumonia. Okay, so based on the options I'm telling, the options how the 4 pneumonias can present I'm telling. Okay, so this is about the this is about a case of a interstitial pneumonia. Okay, then next question. What is the answer? So you people are selecting option B as the answer. Okay, option B as the answer. So most of you have gone for option B and few have gone for COPD. Okay, so I told you we have obstructive lung disease, restrictive lung disease. Okay, and obstructive lung disease, what will happen to the FE1 by FEC ratio? FE1 by FEC ratio less than 70%. Very good, excellent. And what will happen to restrictive lung disease? FE1 by FEC will be more than 70%, or it will be normal, right? So obstructive lung disease, we have A, B, C, right? A for asthma, B for bronchiolitis, bronchiectasis, cystic fibrosis, COPD. RLD means we have intrinsic and extrinsic causes. Extrinsic causes, right? Extrinsic causes, and here it is going to be only thing what we are going to have is kyphoscoliosis. This is also an obstructive lung disease, right? So the answer is going to be B. Okay, B. So this is an X-ray of a patient with kyphoscoliosis, and you can see that one lung is getting compressed like anything. So it is getting restricted like anything. Okay, so this is a case of restrictive lung disease. Okay, restrictive lung disease. Clear? Shall I go to the next question? Hello. Okay. So so there are some doubts, right? I'll clarify the doubts. Don't worry. Okay. So this is a case of patient, okay, with the SLE, increased shortness of breath, TLCO, which is elevated. Okay. So a patient is having SLE. Okay. And this patient with SLE is coming to you. Okay. And he's having acute lupus pneumonitis. There is lupus pneumonitis means it's pneumonia. Okay. It is a non-infectious pneumonia. So what will happen to the DLCO in option A? Decreases. What will happen to the patient's DLCO in pulmonary hypertension? Pulmonary hypertension, it decreases, right? Decreases. Okay. Then shrinking lung syndrome is myositis. Okay, myositis. Because of the myositis, what is going to happen is the muscle is not able to hold the lung, and the lung is going to go for collapse. Okay, so it is kind of restrictive lung disease where the DLCO is going to be decreased, or it can be normal also. Okay, normal. If it is going to be an atelectasis, then it is going to be decreased. Okay, what is pulmonary alveolar hemorrhage? The RBCs are there in the alveoli. So what will happen? The CO will come and bind here. So what will happen to the DLCO? Transfer factor TLCO is equal to DLCO. Increased. So it is going to be increased. Okay, increased. So this is going to be one easy question which they have asked in a different way. One very, very easy question. And even our Harrison says the same thing, right? So pulmonary infiltrates occurs in active SLE, and it is difficult to distinguish infection on imaging studies. Okay, the pulmonary manifestations can be fibrosis, shrinking lung syndrome, intra-alveolar hemorrhage. So these three manifestations can be there. You want DLC or okay. So here many who have gone for this one and many have gone for this one. Okay, what is DLCO? Diffusion lung capacity for carbon monoxide. Okay, so you have a alveoli like this, you have a blood vessel like this. Okay, you give carbon monoxide 0.01% at some minimal dose, and the patient has to hold the breath for 10 seconds. Okay, now what happened is the oxygen is entering here, oxygen is entering here, oxygen is entering here. Sorry, CO is entering here, CO is entering here. Okay, so this CO is a gas which is going to enter into the alveoli. We have two gases, diffusion limited gases and perfusion limited gases. Okay, so here if there is a fibrosis here, what will happen? The carbon monoxide cannot cross the alveolar endothelial barrier. So what is going to happen? The diffusion is decreased. Okay, diffusion is decreased. So anything which involves the alveoli, interstitium, or the blood vessel, okay, is going to have decreased DLCO. Okay, now there is an alveolar hemorrhage where the RBCs are here itself. RBCs are here itself. When the RBCs are here itself, what is going to happen here? What is going to happen? The carbon monoxide will readily find the RBCs. Okay, what happens in emphysema? Emphysema, the membrane is stretched. When the membrane is stretched, what is going to happen to the membrane property or the epithelial property? It is going to be destroyed. you have a balloon, when the balloon is like a balloon, then the membrane is okay. When you stretch the balloon too much, what will happen to the balloon membrane characteristics? It will be changed. The same thing happens in emphysema. There is alveolar epithelial destruction is happening. So in emphysema, it is decreased. Understood, Dr. Harini? Yes, very good, very good. So if they ask you the pulmonary manifestations, okay, so any pulmonary manifestation can be present, okay, but here the question is asked in this manner, okay, in this manner. So this is what I was talking about. This is alveolar hemorrhage, okay, this is alveolar hemorrhage, okay, this is alveolar hemorrhage. Okay, next question. It is going to be C, okay. So extrinsic allergic alveolitis is also known as, it is also known as hypersensitive pneumonitis, right? Hypersensitive pneumonitis, okay. So hypersensitive pneumonitis is type 3, type 4 hypersensitive reaction, type 3 and type 4 hypersensitive reaction, type 3 greater than type 4, and this is acute, this is chronic. Where we saw 1, 3. One, 3 in ABPA, okay, ABPA. This has major criteria, and this is minor criteria in Rosenberg-Patterson criteria, okay, Rosenberg-Patterson criteria, right? So this is what it is going to be type 3 in acute, and type 4 when it is going to be a chronic, where granuloma formation is going to be there, okay. And next question, how you people have done it? So if you see here, many have gone for type 1, okay. Type 1 is going to be an immediate hypersensitivity reaction, but type 3 is because of immune complex deposition. So you have to be, so you know, right, the immune complex formation is going to be here in patients with hypersensitivity pneumonitis, okay, hypersensitivity pneumonitis. So next question. So here, alpha-1 antitrypsin deficiency people have told. So patient has dyspnea, chronic cough with sputum, wheezing, rise of respiratory failure following episode of lobar pneumonia. So young patient coming with recurrent episodes of chest infection, and patient has wheezing, respiratory failure, not a smoker, not a alcoholic, and you can see the lung is getting diffusely involved. Okay, so you can see here. So what answer you people have given? You people have given alpha-1 antitrypsin deficiency predominantly, and exactly that is the correct answer. Okay, so because as Harrison says, it is due to mutation in a locus called Serpina locus. Okay, Harrison says the mutation is at the locus called Serpina locus, and the most common phenotype is going to be this phenotype. This phenotype. There are two types of emphysema. One is centriacinar emphysema, one is panacinar emphysema. The centriacinar emphysema is going to involve the respiratory bronchioles. The panacinar emphysema is going to be panacinus, all the acinus, that is distal to terminal bronchioles is going to get involved. Okay, distal to terminal bronchioles is going to get involved. Okay, and this is predominantly lower zone involvement. They will not have any other contributory factor other than alpha-1 antitrypsin deficiency. Okay, very, very important point to note. You can see the normal alveoli, how it looks, how a panacinar looks. This is panacinar. Okay, hope I am clear. Next question. SARS-CoV-2 attaches to host cells by binding to ACE2 receptor. Very good. So how people have done the exam? Very nicely they have done. They have gone for ACE2. Okay. So here if you see here, the SARS virus will attach to the SARS-CoV-2 COVID virus will attach to the human cell by binding to two receptors, ACE2 receptors and TMPRS receptor. Okay, TMPRSS receptor. ACE2 receptor is a primary receptor which is responsible for the virus entry. Virus entry. Okay, virus entry. And TMPRSS is going to help in priming. Okay, will help in protein priming. Okay, protein priming. Okay, protein priming. Okay, so this is very, very important because it binds to ACE2 ACE2 receptor. Okay, ACE2 receptor. So this is very, very important in COVID. Okay, this can be a potential question in coming exam. Okay, potential question in coming exam. Okay, so please remember this. The primary entry is through ACE2 receptor. Okay, and TMPR is going to be helping in protein priming. Okay, protein priming. Okay, so any drug target can be used here which prevents ACE2 binding. Any drug ACE2 inhibitors, previously they thought that it will increase the risk actually, but any drug in COVID has been in trials. Dalbavancin. Okay, this is one drug which is being tried actually. Okay, the effect is not known, but it is being tried in trials. Okay, Dalbavancin. Okay, so this is one important thing. Okay, important thing you have to remember. Okay, so with this we'll go into the last question in respiratory medicine. Yeah, this receptor, that is down regulation, or whenever you give AC2 receptors. Okay, AC2 receptors, it is told previously, but now they say that there is no much role of AC2. Previously it was taught like that, but it is not so actually. Initial days of COVID it was taught in DM patients there is more AC2, so they are more prone, but there is no evidence. What is this? 60-year-old women with thyroid cancer on treatment with palliative care is admitted due to shortness of breath. What is the best investigation to assess the possible compression of upper airways? So it is going to be a flow volume loop, right? Flow volume loop. Okay, how you people have answered here? So many have answered flow volume loop, but a lot of people have gone for PFR. Okay, so whenever you have a reversible airway condition like asthma, then you can go for PFR. Okay, but whenever there is a problem which is going to be thyroid cancer with or fibrosis of the airway like this. Okay, so it is going to be a fixed obstruction. Okay, it is going to be a fixed obstruction. Whenever you have a fixed obstruction like this, what is going to happen? Whenever you have a fixed obstruction like this, what is going to happen? The patient is going to have pito. Okay, pito. Okay, it depends upon the level, and so the patient is best assessed by a flow volume curve. Okay, flow volume curve. Okay, so pito. What is pito? You know, right? So this is a, for example, I have given this picture. This is a malignancy which obstructs the airway. So what kind of obstruction it is? It is a fixed intrathoracic obstruction. Okay, so if it is fixed intrathoracic obstruction, then what you're going to get is you're going to get a box shaped curve. Okay, you're going to get a box shaped curve. Okay, so for just a quick recall, what is this curve A indicates? What is this curve A indicates? This is a actually a normal curve. Very good, normal curve. Okay, normal curve. What is this curve B indicates? This is, which one is affected? Inspiratory part is affected or expiratory part is affected? So this is going to be a variable extrathoracic obstruction. Excellent. Okay, here expiratory part is affected, so it is going to be a pito. Right, what is this curve? What is this curve? D. It is going to be a Pito, right? Pito. What is this curve? Curve E. RLD means, okay, RLD you will get like this. So this is obstructive lung disease pattern, but if it is like this, then it is going to be a restrictive lung disease. So with this, we are finishing. Yes, scooped dog ear or scooped ice cream appearance, right? Okay. So with this, we are finishing respiratory medicine. I will give a break definitely. So how you people feel after just now? I mean, last week you attended the answer is D, flow volume loop. Okay. So how you people feel after attending respiratory medicine class last week and solving these questions? How is your experience? I want to hear from you people. How is your experience? So next we'll go for neuro. So this is very once you know subject nicely, so how interesting the clinical questions are. Okay, the clinical questions, if you are not attended the regular class and if you're attending these questions, you might feel difficult. I would have made more complicated single liners. Okay, that is of not much use in upcoming exam. So this kind of thing will be very helpful for you to crack and think in your exam also. Okay, think in your exam also. So this is very important. Okay, so with this I will finish respiratory medicine. So the next thing what I'm going to do is I'll go for neurology. Okay, so again neurology is one of the fascinating and one of my favorite thing. Okay, so I hope I have made a proper set of questions in neurology also. So after the break of 10 minutes we'll go into the neurology. Okay, neurology. Any doubt, I will give my number at the end of the class. Okay, you can message me and ask me. Okay, so now we'll go for a break, then we'll start with neurology. So shall we start? So have you been back? So I hope I'm audible and I'm seen also. So next we are going to go to one important topic, personal favorite and many one's nightmare. One topic which is going to make people wonder what is it. Okay, so that is going to be neurology. Okay, so one of the important topic for your exam. Okay, many feel that 1 second, I'll switch on the light. Hope it is bright now. So here the important topic is neurology. So the first question in neurology is, a 40-year-old man sustained minor head injury. This minor head injury is followed by he was struck on his head by a cricket bat. Okay, so then he had a sudden onset of headache, nausea and vomiting, and then onwards the patient developed weakness over the left side. Okay, left side. Okay, a CT scan was done which shows blood collection on the left side. Okay, so this I made little easy by labeling the structures. Okay, if it had not labeled the structures, it would have been little bit tough, I think so. Okay, so little bit tough, I think so. So what the people have answered, okay, what people have thought and what people have answered, we will see. So this question, many have gone for only option C. I'm very happy to see this because it is an excellent response that you people have gone for option C. Okay. So why it is C? What is Kernohan-Waltman sign? What do you mean by it? Okay, whenever there is a herniation, there is something going to happen. Okay, something going to happen. Okay, so what happens whenever there is an raised intracranial pressure? What is going to happen is there is going to be herniation in the brain. Okay, herniation in the brain. Okay, there are different types of herniation. Okay, along with the herniation, what is going to happen is there is going to be brain compression. Okay, and this compression results in Cushing's triad. Okay, Cushing's triad. So what is Cushing's triad? Cushing's triad is a patient with a raised ICP presenting with the decreased perfusion within the brain, okay, resulting with bradycardia, systolic hypertension, and irregular breathing. Okay, that is called as Cushing's triad. Okay, so this is because the pressure on the brainstem causes these things. Okay, usually the patient will present with Cushing's triad with headache, vomiting, and papilledema, raised ICP changes. Okay, and you will have herniation. Okay, so there are different types of herniation. The herniation number 1. Okay, what is this one herniation is called as? Number 1 here. This is called as cingulate or subfalcine herniation. Very good. Subfalcine herniation, cingulate or subfalcine herniation. Very good, Dr. Vishnu and Dr. Rakshana. Very good. This is cingulate or subfalcine herniation. Okay, this is cingulate or subfalcine herniation. Very, very important. Okay, what is this 2? So singulatus to opposite side. What is 2? 2 is central or transtentorial. Okay, transtentorial. Okay, this is through the tentorium it is going. Okay, and 3 is uncal herniation, or it is also called as again transtentorial. Okay, transtentorial. What is 4? What is 4? Tonsillar. Okay, tonsillar herniation. Tonsillar herniation. Okay, herniation. Sometimes this part will herniate like this. Okay, this is ascending transtentorial. Okay, it is ascending transtentorial. This part 5. I will label it as 5. Okay, and sometimes brain will herniate into the calvarium. It is called as transcalvarial herniation. Transcalvarial herniation. Okay, so whenever you have a lesion like this in the brain, okay, this is a left-sided lesion. So which corticospinal tract fibers will be compressed? Which corticospinal tract fibers will be compressed? It is going to be left. Okay, when left is getting compressed, which side patient will develop hemiparesis or hemiplegia? It is right. Okay, right. But here, what is going to happen is, paradoxically, this uncal herniation is going to compress the ipsilateral corticospinal tract, and it is going to cause same side hemiparesis. Okay, same side hemiparesis, and this patient develops same side hemiparesis, and this is called as Kernohan-Waltman sign. Okay, Kernohan-Waltman sign. Okay, Kernohan-Waltman sign. Very, very important thing for your exam. Okay, Kernohan-Waltman sign. Very, very important sign. Okay, Kernohan-Waltman phenomenon. Okay, so it is a paradoxical ipsilateral weakness due to the compression. Okay, due to the compression. Why? When this goes down, because of the pressure, this is going to compress the opposite side. Okay, so the fibers coming from the opposite side are getting compressed. So the patient is going to develop left hemiparesis. Left hemiparesis. Okay, so this is very, very important. Okay, very, very important. This is called as Kernohan-Waltman sign, because our brain is like a closed box. According to the Monroe's doctrine, our brain is a closed box. Okay, so because it is being a closed box, the compression results in this kind of phenomenon called as Kernohan-Waltman phenomenon. Okay, Waltman phenomenon. Hope you understood this. This is very, very important to know. Okay, very, very important to know. Okay, so please understand this concept. This is very, very important. Okay, very, very important. Okay, so next question I will go. Okay, I'll show you some pictures. What does this indicates? This picture, what does this picture indicates? There is a ICH, and you can see that this is at the level of brainstem. So this is because of this part is getting pushed down. Okay, so this is a case of Kernohan-Waltman phenomenon. This is going to be an uncal herniation. Here there is an uncal herniation. Uncal herniation. Okay, what does this picture indicates? You can see here there is an herniation here. Okay, this is tonsillar herniation. Okay, tonsillar herniation. In which condition it is associated? This tonsillar herniation is seen in Arnold-Chiari. Very good, Dr. Rakshana. Arnold-Chiari. What it is associated with? Type 2 in central cord syndrome. It is associated with central cord syndrome, or it is going to be causing dissociative anesthesia, or it is going to be associated with syringomyelia, syrinx. Okay, syringomyelia. Okay, so this is very important for you to know. Okay, then I'll go to the next question. What is the answer here? Answer is C, you say. Okay. What is A? A is anterior spinal artery syndrome. So it is 3. B is anterior horn cell is getting involved. So it is going to be 4. And C is going to be central part is getting involved. So it is going to be syringomyelia. And D is posterior column is getting involved. So it is going to be SACD. So it is going to be 2. Okay. So how many of you have done it correctly? So if you see here, so many have gone for C only correctly. Okay, correctly. So this is again one of the important concepts which you should never forget when it comes to the brainstem and the spinal cord. Okay, so the first one is going to be anterior spinal artery syndrome, where the patient has an infarction of the cord. So this is part is supplied by anterior spinal artery. This is by posterior spinal artery. So this anterior 2/3 is supplied by the anterior spinal artery. So it is going to involve the spinothalamic tract and the corticospinal tract bilaterally, sparing the posterior column. So this is what again Harrison says. Okay, Harrison says that all spinal cord functions, motor, sensory, autonomic, are lost below the level of lesion, with striking exception retained vibration and position sensation. So I call it as VIP sensation is preserved. VIP sensation is preserved. So this is anterior cord syndrome. Okay, anterior cord syndrome, very, very important to remember this. Very, very important to remember this. Okay, this is anterior cord. Then we all know that polio, there is going to be involvement of the anterior horn cell. Okay, so it is going to be one of the differential diagnosis for acute flaccid paralysis. Okay, acute flaccid paralysis. Okay, so next is syringomyelia, where as like this, the central part of the cord is getting involved. There is a fluid filled cavity which expands most commonly anteriorly. Okay, thereby it will compress the crossing fibers of spinothalamic tract. So the patient is going to have a loss of pain and temperature, especially over the area involving T8 and T1. And these patients are going to be associated with the dissociative anesthesia or suspended anesthesia, which is also called as cape distribution. So everything is, this is from Harrison. Okay, this is from Harrison. Okay, so these patients are going to have loss of pain, temperature sensation, sparing touch and vibration. Okay, so this is a dissociative anesthesia. Okay, over the neck, shoulder, and upper arms, especially over C8, T1, and this is called as cape distribution. Okay, cape distribution. And most of the time, the patient it involves asymmetrically, and the patient is going to have painless burns. I usually used to tell this: the patient is going to have painless burns. Painless burns. This is called the central cord syndrome. And next what we had posterior column involvement. Posterior column involvement is there along with the involvement of corticospinal tract. So these patients, okay, this is from Harrison, and the most important point you have to remember, the most important point is the patient is going to have loss of VIP sensation, vibration and position. Apart from that, the patient who is having loss of reflexes because of peripheral neuropathy, corticospinal tract involvement, there is going to be loss of reflexes. Along with that, the patient is going to have a Babinski sign positive. Okay, if this combo is present, then the patient is having posterior column involvement due to subacute combined degeneration due to vitamin B12 deficiency. And this is the MRI finding where you are going to get an inverted V sign like this, or it is also called as inverted rabbit ear appearance. Okay, it is also called as inverted rabbit ear appearance. Okay, inverted rabbit ear appearance. Okay, inverted rabbit ear appearance. Okay, so this is about this thing. And based on the question, so your answer is C. Okay, so coming back here as a fast revision, in syringomyelia, spinothalamic tract is getting involved. SACD, posterior column and corticospinal tract is getting involved. Anterior spinal artery occlusion, spinothalamic tract, corticospinal tract is getting involved. In tabes dorsale and posterior spinal artery syndrome, we are going to have posterior column involvement alone. Okay, posterior column involvement alone. This tabular column is very, very important. You can take a pic of it. It is going to help you in your exam. Okay, in your exam. Okay, shall we go to the next question? Yes. So next question is this one. Your professor teaches that strokes can be divided into hemorrhagic and ischemic types with subtypes, and he shows patients of various clinical features. Which of the following subtype of stroke has strongest association with cognitive impairment and vascular dementia? Your answer is C. Many people are saying C. Okay, one previous slide. Yes. So, okay, fine. Very good. So, ischemic strokes, small vessel subtype. Okay. So, what they want to know, whether it is a vascular dementia is associated with what. Okay. We all know that vascular dementia is associated with two things. Okay. One is called lacunar stroke. Another one is Binswanger disease. So there is going to be arteriosclerosis with atherosclerosis causing blockage of blood vessels, that is small penetrating deep branches. So if it is going to be a complete occlusion, then it is going to be a lacunar stroke. Whenever it is a partial occlusion, then it is going to be a Binswanger disease. Okay, so this we know already as we discussed in our regular class. Okay, but what Harrison says, ischemic stroke compose 80% of all strokes. Okay, large vessel and small vessel disease can lead to dementia. Okay, but large vessel disease is associated with 18% of cases, and small vessel disease is associated with 36 to 67% of patients. Okay, so which is more common? Small vessel disease. So if they ask you in your exam, small vessel disease is associated with the stroke. Okay, there is no doubt in this. This Harrison itself says this, and this is going to be the key most of the time. Okay, so it is going to be a small vessel disease. When you will suspect a vascular dementia, whenever a patient with atrial fibrillation or history of TIA has rapidly progressive dementia less than 3 months duration, then think about small vessel disease causing vascular dementia. Okay, so lacunar stroke is associated with vascular dementia. Okay, next. You posted as an intern in neurology department, and NEET-PG is fascinated that a drug has arrived in a pharmacy and it is highly effective and targets CD20 on the surface of mature B cells. Which of the following medication is used to treat when he develops recurrent episodes of weakness followed by bladder dyssynergia? So this patient is going to have multiple sclerosis because this patient is having weakness, okay, and bladder dyssynergia. So if the patient is having a bladder where there is going to be no synchronization between the bladder and the sphincter. Okay, so this patient has a demyelination syndrome. Okay, and because of this, this patient is going to have a relapsing and remitting type of multiple sclerosis here based on the history I'm telling. Okay, so whenever you have a demyelination syndrome, okay, what Harrison says is you have a lot of options to give to the patient, and I usually used to tell in my class that it is going to be Fingomed, okay, F for Fingolimod, interferon beta, natalizumab, glatirimab acetate, ocrelizumab, M for metoxantrone, alemtuzumab, DMF. Okay, so these are the drugs. Okay, so here this drug is going to be the drug of choice in PPMS, primary progressive multiple sclerosis, where it is going to target anti-CD20. So that is the drug which is going to be used. Okay, so that is what Harrison also says. Ocrelizumab is a humanized monoclonal antibody directed against CD20 molecule present at the surface of the mature B cells. Okay, it acts on the mature B cells. Okay, mature B cells, not on the early B cells precursors. Okay, early B cells precursors, and it is going to be the drug of choice in primary progressive multiple sclerosis. Primary progressive multiple sclerosis. Okay, so this is very, very important. This is what Harrison says. Okay, so this is based on the Harrison. Okay, and I will ask you one more question. What is the thing about natalizumab you will think when you get a question on natalizumab? What is the thing which is going to make you think? So you always screen for JC virus because it is going to cause progressive multifocal leukoencephalopathy. Progressive multifocal leukoencephalopathy. Okay, so this is very, very important. So how you people have attended the exam? So in the exam, this question also you have done correctly, but here many have gone for hemorrhagic stroke intracerebral type. Okay, that is wrong. And here many have gone for natalizumab. Okay, natalizumab is one reserve drug actually. When more than 2 drugs fails, then you can go for nata. Okay, it is highly efficacious, but the side effect profile is very high. So for that reason, you don't go for nata. Okay, then acrelizumab is the drug of choice. Okay, acrelizumab is the new drug, acts on CD22. Okay, then this question we are going to come. I'm surprised this question was answered by you people nicely. Okay, so because this question, many of you, a 70-year-old female is seen by a neurology clinic suspected with cognitive impairment and told by a specialist to do a simple test. What was a simple test? To subtract from 100. 100 minus 7, 93, 93 minus 7, 86, 86 minus 7, 79, like that. Okay, so what is the answer here? What is the answer here? It is attention. I'm very happy that you people attended this question nicely, because if you see here, most of you have answered it as attention. Okay, I'm very happy to see this because it is based upon a scale called Montreal Cognitive Assessment. Okay, there are a lot of scales are there, but I'm going to give example as Montreal Cognitive Assessment. Okay, Montreal Cognitive Assessment is called as MOC scale. Okay, MOCA scale. Okay, so what is this MOCA scale or MOCA scale? Okay, the scale is having few things which you will select and you will calculate the score and you will tell to the patient. Okay, the first one is called as visuospatial or executive scale. Okay, so here what happens is the patient will start from 1 and he will go to 2, then 3, okay, then 4, 5, like this. Or what he can do is he can go from A, B, C, D, E, like this he can go. Okay, so like this go. This is called visuospatial executive. Then naming. Okay, naming. What he does, he will tell lion, rhinoceros, camel. Okay, and the patient will be given 5 things to remember. Okay, so and he will be asked after few seconds, okay, or to few minutes, okay, whether he will able to tell correctly. Again, he is able to tell correctly, like that you are going to do. Okay, then what you are going to do is you are going to check for the attention. That is what we were discussing. Okay, attention is patient is told to tell from 100 minus 7 or 100 minus 9, 91 minus 9, then 82 minus 9, like that he is going to tell whether he is paying attention to the number 100 minus 9 is 91. Okay, whether he is able to pay attention to this number, minus 9, whether he is able to pay attention to this number. Okay, that is called as attention. If he is not able to tell 900 minus 9, 92 minus 9, 86, like that. He is not able to pay attention to the number. That is called as defective attention. Okay, then you can tell read a list of letters. Okay, so you can tell from this CBA, tell them to point out the numbers, whether he is able to pay attention to you. Language, you can repeat a language. Abstraction, okay, what is abstraction? You can ask what is the similarity between banana and orange or grapes if it is a fruit. Okay, then you can ask what is the relation between tube light and a fan. It runs by current, okay, electricity. Okay, so like this you can ask to the person. Okay, and delayed recall, the previous memory what you checked for, you will tell the patient to tell again. Okay, then optionally you can check for the orientation also. Okay, so orientation is orientation also you will check. You will ask for today's date, month, year, okay, which day it is, where are you, and which city it is, like that you will ask. Okay, and a score of more than 26 is normal. Okay, a score of more than 26 is normal. Okay, this is very, very important. Okay, very, very important. Coming to next question. A 70-year-old male is seen in your clinic. According to his son, he lost his ability to engage in meaningful conversations, does not appear to understand what is said to him, and he speaks fluently and happily. He is able to repeat sentences, but is impaired understanding when single-step verbal commands were given to him. So many of you say here as answer as D. You will see what you told in exam. You told D, but more number of people has told B. Okay, if you would have attended CNS class, then it is going to be an easy question for you, because we all know that this is a person. Okay, don't stare at this person. This person might look a little awkward. This is going to be the temporal lobe. Here we have Wernicke's area. Inferior frontal gyrus, we have the Broca's area. Both are connected by the arcuate fibers. Okay, and we have here transcortical motor, transcortical sensory. Okay, so whatever you speak, okay, okay, the person hears and understands, connected to Broca's area, and comprehends, understand and produce words fluently. Okay, for this it is required, and these 1, 2, 3 are required for repetition. Okay, repetition. So this detailed I will explain in the regular class. Repetition. Okay, and this transcortical motor and transcortical sensory are similar to Broca's. Okay, similar to Broca's minus repetition, because repetition will be normal in transcortical motor and transcortical sensory. Okay, transcortical sensory. So this patient with the Wernicke's aphasia will not understand. Okay, so he will produce non-meaningful word, okay, but fluently. These Broca's aphasia will produce meaningful words, that is, he understands meaningful words but breaks in between. Okay, and it is not fluent, and it is agrammatical. In all these conditions, repetition will be lost. Okay, but in transcortical motor and transcortical sensory, repetition will be bad. Okay, the detailed explanation will be given in the regular class. So here, if you see here, this patient has lost his ability to engage in meaningful conversation. Okay, so what it means, he doesn't understand. Okay, doesn't understand, but he is talking fluently. If he is talking fluently, means this part is intact. Okay, then repetition is normal. Repetition normal means then this part is not involved, this part is involved. Okay, this part is involved. So this case is a case of transcortical sensory. Understood, right? Understood, right? It was a fast thing. Detailed I will tell in the class also. Okay, so this is fast. I just want to make you to remember things. Okay, so Wernicke's comprehension or understanding is impaired, repetition is impaired, naming is impaired, fluency is preserved. If you take Wernicke's, the similar thing will be seen in the transcortical fluent, okay, where repetition is preserved. Can you understand? Can you make the difference? This is from Harrison. This table is from Harrison. Can you make the difference? Can you make out the difference? Okay, so hope you understood the difference between the two conditions. Okay, two conditions. Yes. Okay. So this is what I was telling. Okay. So whenever the patient has an impact repetition with impaired comprehension or understanding, fluency is normal, then it is going to be a transcortical sensory aphasia. Okay, transcortical sensory aphasia. And many people have gone for Wernicke's. Okay, but the answer is transcortical sensory aphasia. Okay, transcortical sensory aphasia. So again, our Harrison is one beautiful book which is going to give you the answers whichever you ask in exam. Okay, so fluent transcortical aphasia similar to those of Wernicke's aphasia, but repetition is intact. Repetition is intact. Okay, so this is very, very important because it is an association area getting involved. Okay, next question. So here, many people have gone for dementia with Lewy bodies. Okay, as you say from your answer now, what you have done in your exam. So many have gone for dementia with Lewy bodies. Excellent response. Okay, excellent response. Very happy. People have responded in a correct for the correct answer in a nice way. Okay, so what is this cingulate island? Okay, cingulate island. So this is a case of Lewy body dementia. Okay, this is an FDG PET done. You can see this, right? FDG PET done in a patient with uh, Lewy body dementia, diffuse Lewy body dementia, where it is going to spare the cingulate cortex. This is the cingulate cortex. This is the cingulate cortex. This is the cingulate cortex. It is spared and it is going to involve the occipital lobe. You can see the hypometabolism in the occipital lobe. You can see here. You can see here there is hypometabolism in these two parts, but there is going to be a cingulate sparing. Okay, this is what's seen in PET in patient with the diffuse Lewy body dementia. Okay, it is seen in diffuse Lewy body dementia. Rather, in a patient with Alzheimer's disease, what is going to happen is in Alzheimer's disease, it is going to be involving the temporoparietal region. Okay, temporoparietal region, and later on occipital lobe is also can be getting involved. So here you can see here, this is going to involve the temporoparietal region. Hypermetabolism in the temporoparietal region. Okay, this is what disease? This is Alzheimer's disease. But this is diffuse Lewy body dementia. You can make out the clear difference. Okay, clear difference. Okay, you can see here. So this is one important thing you have to remember. Okay, so I will go to the next question before going to the next question. So you people have done it very nicely. So I will go to the next question. So what is your diagnosis from this history? Whoever diagnoses this will get a dairy milk from me. I want the diagnosis first. You will get a dairy milk. You will get a dairy milk. Dairy milk question. I'll send through parcel or through ADR, thought through in the next class. Okay. No, 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 no. Answer is D. I am happy with that, but I want the diagnosis based on the history. So everyone thought that this cat is the trump card, okay, but this cat is the distractor. The cat moves here and there in front of you and it distracts you. Okay, now I will come to the question. The patient had right-sided weakness. Okay, right-sided weakness. So the patient had right-sided weakness. Okay, right-sided weakness. Left-sided ataxia. Left-side ataxia. Hoarseness of voice. 10th nerve is getting involved. Numbness over left side of the face. Numbness over left side of the face. Okay, he has ulceration over the right face, over upper lip, right face, upper lip. Okay, and nose. Okay, and it does not cross the midline. Okay, midline. Then this indicates the patient has involvement of the medulla. So it is a medullary infarct. I cannot say exactly this is a Wallenberg. Okay, this is not exactly Wallenberg. Okay, it is combination of Wallenberg with medial medullary, that is lateral medullary with medial medullary syndrome. Combination is present here. Okay, combination is present here. This is in Wallenberg. Okay, so there is a combination of medial medullary with lateral medullary features. Okay, and this patient has trigeminal trophic syndrome. Trigeminal trophic syndrome. Okay, so this is a condition usually it is associated with lateral medullary syndrome. Usually it is going to be associated with lateral medullary syndrome. Okay, this weak want to tell it is a sensory involvement. Okay, sensory involvement. If it is sensory involvement, then it is going to be more correctly a Wallenberg syndrome. Okay, and this patient is having all over the face ulcers. The ulcers are like this. Okay, so this is called trigeminal. This is because of the medullary involvement. Okay, trigeminal trophic syndrome. Okay, trigeminal trophic syndrome. This is trigeminal trophic syndrome. Okay, more commonly it can involve the lateral medulla. Okay, sometimes medial medulla can also get involved, but lateral medulla is getting involved, so fifth nerve is getting involved. Okay, I will teach you in lateral medullary syndrome, and you can see the ulcer over the face. Okay, this is called as trigeminal trophic syndrome. Okay, trigeminal trophic syndrome, and many of you have done it correctly, but many have gone for cat scratch disease. But this is going to be a distractor. This is how the exams questions will be framed to distract you. Okay, here the cat is nothing to do with the diagnosis. Okay, cat has nothing to do with the diagnosis. Okay, shall I go to the next question? So many have gone for option C. Option C. Okay, what is option A? Option A. It is Brown-Sequard syndrome. Very good. What happens in Brown-Sequard syndrome? What happens in Brown-Sequard syndrome? Half cord is getting cut. Okay, half cord is getting cut. Half of the cord is getting cut. Ipsilateral. So these are the crossing fibers coming here. Okay, crossing fibers coming here. So ipsilateral, VIP, ipsilateral, hemiparesis, contralateral, pain and temperature. Okay, pain and temperature. Okay, so that is what happens. Okay, that is what happens. Okay, then option B. Option B. It is option B. It is syringomyelia. Okay, syringomyelia, CAT1 distribution is getting involved. Option C is brainstem involvement. Okay, brainstem involvement. This is called as crossed hemiplegia. Crossed hemiplegia. And what is this? This complete hemiparesis. The lesion is in the cortex or internal capsule. Internal capsule. Okay, so this is answer is C. So what people have done here? People have gone for only C. Very good. Okay, so very good. Okay, then next question is, a 65-year-old male is rushed to cardiac ICU following prolonged cardiac surgery for aortic valve. He is found to have altered speech, difficulty in swallowing. He is known case of hypertension on enalapril. Smoker. His speech is hypophonic. You note deviation of tongue to the right on protrusion. Okay, right on protrusion. Laryngoscopy shows vocal cord on the right. What is the answer? What is the answer? So what people answer D, someone is telling here. What people have answered? People have answered as lateral medullary syndrome, but the answer is Tapia syndrome. Okay, Tapia syndrome. Why this is not lateral medullary syndrome? Only in medial medullary syndrome we will have 12th nerve involvement. Okay, plus this is ipsilateral side. Then contralateral side we are going to have corticospinal tract involvement. Contralateral VIP is getting involved. That is medial medullary syndrome, but nothing they have given like this. So here what they have given the patient has 12th nerve involvement with vocal cord paralysis. More or less, okay, the patient has like this. The patient is like this. This is not exactly, this is, the tongue is deviated to the left side actually. Okay, and you can see the vocal cord is in this position, abducted position. So when you intubate the patient, what is going to happen is there is going to be compression at this level, which is going to compress the 12th nerve and recurrent laryngeal nerve. Okay, recurrent laryngeal nerve. And because of this, what is going to happen is the tongue is deviated to same side. And because of the recurrent laryngeal nerve palsy, the patient is going to have a dysphonia or hypophonia like feature. Dysphonia or hypophonia like feature or vocal cord paralysis. Okay, this is usually seen after prolonged intubation, and this is called as Tapia syndrome. Okay, Tapia syndrome. So how people have answered? Less people have answered Tapia syndrome. So the answer is Tapia syndrome. Tapia syndrome. Clear? Tapia syndrome. Okay. So 12th nerve with 10. 10 plus 12 is Tapia. Next question. A 60-year-old female referred to your clinic with a diagnosis of trigeminal neuralgia. She mentions 4 weeks before she felt numbness in an area on the right side of below the lower lip while drinking coffee. This area, she has numbness. This was persistent and she denies any dental problems or any recent dental work. Neurological examination reveals reduced sensation in the area shown below. Which one you want to explain? Dr. Tanuja? Tapia. Okay, see in Tapia, what is going to happen? There is 12th nerve palsy with vocal cord palsy. Okay, so whenever you put the patient on intubation for prolonged duration, what is going to happen is this ET tube is going to compress the recurrent laryngeal nerve and the 12th nerve, and because of the compression, few patients may develop edema over this area, and this edema causes compression over this both the nerves for a prolonged duration. So patient is going to develop difficulty in speaking, and patient has difficulty in protrusion of tongue. The tongue is deviated towards the same side, so it is called as Tapia syndrome. Okay, so this is, you are telling answer as D, right? D. Okay, we'll see how many people have answered it correctly. So very less number have answered as malignancy. Okay, I mean, many people have answered as Sjogren's, sarcoidosis, SLE. Okay, so what is this condition? This is called as numb chin syndrome. Okay, numb chin syndrome. Numb chin syndrome. Okay, so this is an area supplied by the mental nerve. Okay, this is an area supplied by the mental nerve. That area has hyposthesia, decreased sensation. Okay, so usually it is caused by dental problems. If it is not because of dental problem, then you have to think about some malignancies. Okay, malignancy. Okay, and most commonly it is associated with breast carcinoma. Okay, breast carcinoma for unknown reason. Okay, otherwise you can go for other causes like multiple sclerosis, diabetes, but it is most commonly associated with malignancy. This is called as numb chin syndrome. Okay, so numb chin syndrome is one a new entity you are reading today. Okay, new entity you are reading today. Next question. A 40-year-old male has diplopia, distal paresthesias, sensory ataxia, global areflexia, and limitation of eye movements, and anti-GQ1B antibody positive. What is your diagnosis? So many people, what they have done is they have gone for Miller-Fisher syndrome. Okay, many have gone for Miller-Fisher syndrome. Okay, but the answer is CanoMAD. Okay, CanoMAD. Okay, what is this CanoMAD? CanoMAD. I will tell you why this is CanoMAD. These patients are going to have chronic ataxic neuropathy. Chronic ataxic neuropathy. And they're going to have ophthalmoplegia. IgM paraproteinemia. Okay, IgM paraproteinemia. Okay, and these patients are also going to have agglutinin diacyl antibody. Agglutinin and diacyl antibodies. Okay, that is called CanoMAD. Okay, so this patient, who came to you, we're having sensory ataxia with global areflexia, okay, with diplopia and paresthesias and raised IgM level. Okay, so this one is the key point here, because GQ1B antibody. So GQ1 body, I usually tell it is a Fisher syndrome, Miller-Fisher syndrome. The thing which differentiates this from our CanoMAD is going to be our IgM levels. Okay, so this is going to be the trump card here. Okay, trump card here. So whenever you have a differential diagnosis, you are going to have three important differential diagnoses here. Okay, so first one is going to be Miller-Fisher syndrome, which is characterized by ophthalmoplegia, okay, areflexia, and ataxia. Okay, then Bickerstaff encephalitis, many times they say that it is associated with hyperreflexia. Bickerstaff encephalitis is associated with hyperreflexia, and the patient is going to have an altered sensorium. Okay, Guillain-Barré syndrome will have areflexia with symmetrical weakness. Okay, so here it is going to be GM1 ganglioside, here it is going to be GQ1 antibody. Okay, but the differentiating feature from CanoMAD from Miller-Fisher syndrome is going to be your IgM levels. Okay, the only trump card in that question was IgM levels. Okay, the trump card, if you use the trump card properly, if you throw the trump card properly, what is going to happen? You're going to get the correct answer. Okay, So always watch for the trump card. Look like an eagle. Okay, be keen like an eagle. Move around the question like a fish. Okay, so you will move around the question like a fish fastly. Especially you will move around the question and look for the trump card. Okay, so again, this is going to be telling this the same thing: ophthalmoplegia, ataxia, areflexia, but here also GQ1B antibody is present. Okay, so how you are going to differentiate this? Differentiate by IgM levels. Can nobody want to show? See once. This is the trump card. Stop it. Yes. Okay. We'll go to the next question. A 55-year-old male with diabetes and hypertension referred with double vision and right-sided facial weakness. On examination, complete horizontal paralysis of the right eye is present. The left eye can abduct but cannot adduct. Nystagmus is present on abduction of the left eye. There is facial weakness on right side with no wrinkling in the forehead. So what you're going to tell? Right pontine tegmentum. So I want you to tell the diagnosis and the justification. So that will be more helpful in understanding the concept. So why right pontine tegmentum? So tegmentum means more of ventral part is getting involved. Okay. So here what happens is the patient has, okay, patient has which side facial weakness? Right sided facial weakness. So this is going to be 7. Okay. Then coming to next thing is the patient has MLF with PPRF. Okay. When MLF and PPRF is getting involved, what is going to happen? The lesion is in the right side. So this is gone and this is gone. Okay. Only one possible movement is this abduction. Okay. So half is gone. So 1.5 eye syndrome is present. Okay. So 7 plus 1.5 eye syndrome. Okay. More of MLF is getting involved. So patient is going to have 8.5 syndrome. Right. So as Dr. Bhuvana and Dr. Priya told, it is Povili syndrome. Okay. Povili syndrome, where I usually used to tell like this: Povili is in Tamil, it is Puvili. Okay. When the vision is affected, okay, horizontally, then think about Povili syndrome, facial nerve palsy with patient having ophthalmoplegia with weakness. Okay. Then it is going to be Povili syndrome, but they have not given here weakness. So actually, this is the patient. What you see here, no movement. Okay, no movement present. On looking here, no movement. Okay, so 1.5 eye syndrome. And what is seen here? Facial nerve palsy. So what is the syndrome called as? It is an element type of facial nerve palsy. So this is going to be a 8.5 syndrome. So which part is getting involved? The part getting involved is going to be the tegmental part. Okay, tegmental part. So this is a case of 8.5 eye syndrome. Okay, 8.5 eye syndrome. Right. So how many of you have done it correctly? Here, many have gone for right pontine tegmentum, very happy. So seventh nerve, eighth nerve is getting involved with MLF like feature, then it is going to be pons. Okay, pons. That is very sure. Right side is getting involved, right side feature is there, so right pontine involvement. So here only thing is right pontine tegmentum is given. Okay, right pontine tegmentum is given. Okay, then next question. 86-year-old woman presented with chief complaints of visual hallucination. She had been having these visions for a week, occurring mainly in the evening. The hallucinations are episodic, binocular, and lasted for few hours. She had a good vision in the left eye, but has macular degeneration. Neurological examination is normal. She scores a MoCA of 27/30. She is able to draw a clock face without difficulty. Which of the following is the most likely diagnosis? So this is a patient with visual hallucinations. Otherwise, her sensorium is normal, and she has macular degeneration. Macular degeneration means what? She is having some kind of blindness. Okay, it's acquired blindness secondary to diabetes, and the patient has visual hallucination. So, what is the answer? The answer is D. Okay, so if you have told it is D, so what people have told D. Many have told D. Okay, so what is D? And here also you can get similar complaints. Okay, so peduncular hallucinosis, whenever midbrain is getting involved, you will get peduncular hallucinosis. Okay, there also you will have hallucinations where objects will be moving around. Okay, familiar objects will be moving around them. Okay, but here in Charles Bonnet syndrome, a blind person is developing visual images, okay, like this, okay, visual images, and they will have a history of macular degeneration or any other acquired blindness is there which affects the visual pathway. Okay, so you are moving in the car like this. Okay, you are moving in a car like this. Suddenly, what happens is you see dogs sitting here and there. Okay, a misinterpreted image is seen. Okay, so this is called as Charles Bonnet syndrome. Okay, Charles Bonnet syndrome. Okay, so the patient will have hallucinations. Okay, which is very classically seen, called as Charles Bonnet syndrome. Charles Bonnet syndrome. Okay, Charles Bonnet syndrome. So this is again one nice question. Okay, I feel this can be asked in your exam. Okay, so next question is this one. Next question is this one. I want the diagnosis, then we'll go for it. 40-year-old male comes to casualty describing of strange visual phenomenon. Okay, visual phenomenon, and he was told briefly to take rest. When he came around, he felt everything turned upside down. He saw the players walking on heads. CT brain is normal. Advised MRI. What is the area involved? So what is the diagnosis? Diagnosis. Can you tell the diagnosis? If you tell the diagnosis, I'll be very happy to hear that. I'll be very happy to hear the diagnosis from you. It is a case of like this. Okay, so a patient has inverted images. Okay, inverted images that lasted for only couple of seconds. This is about a patient where that lasted for only couple of seconds. Okay, and he denied any visual acuity changes and all. Okay, so everything was normal. Okay, so this patient, when you give a cup of tea like this, he will see the tea like this. So this is called as reverse metamorphosis. Reverse metamorphosis. Okay, when you give him a cup of tea, he will get the cup of tea like this. Okay, it is reverse metamorphosis. When he is sitting in a hall and sees images, it is look like this. Okay, so whenever there is a reverse metamorphosis, the region of the brain getting involved is going to be either a occipitopalatal region, brainstem, or cerebellum. It is related to vision, where the patient got head injury, followed by the patient is going to have a feature like this. This is called as reverse metamorphosis. Okay, reverse metamorphosis. Hello. Now 8 o'clock or 8 o'clock. Yeah, appointment. 8 o'clock. Okay. This is called as reverse metamorphosis. Okay, reverse metamorphosis. Okay, so this is about the reverse metamorphosis. Okay, reverse metamorphosis. I'll come to the next question. So, how many of you answered this? So, many have answered this. Many have answered this parietal lobe. Okay, and cerebellum also you have involved. So, anything below the occipitopalatal cortex or the cerebellum is called as reverse metamorphosis. Okay, so I will come to the next question. A 30-year-old male seen in clinic with right-sided optic neuritis 2 weeks ago. So he was on steroids. However, he mentions problem in depth perception. He was playing shuttle and has recently struggled to play the shuttle. Why? He's playing shuttle like this. The ball will go like this and the ball will come like this. Okay. So he describes watching his friends playing standing at the side of the court. That time also, he feels that the ball is moving around like this, not in a straight line. What is this? This is, what is the diagnosis? What diagnosis you want to make from this? Very good, excellent, Dr. Prashant. This is very good, Priya, Dr. Akshara. Multiple sclerosis you are suspecting. Okay, so here you are going to get an effect called full-fridge phenomenon. What is Utah phenomenon? Hot water or heat provokes an attack of transient monocular blindness. Okay, blindness will be there. Okay, what is apnea effect? Apnea effect. Okay, when you see a color, whenever a light color is introduced, the color perception will change. Okay, that is called as apnea effect. Okay, that is called as apnea effect. Okay, then what is the next one? Poggendorf illusion. See, you didn't understand. Okay, you have a blue color light. Okay, suddenly what happens? A mixture of white light is introduced. Okay, white light is introduced, and when you see that blue color, you will not see the blue color. You will see it as a white color. That is called as apnea effect. Okay, apnea effect. Blue color will not be seen as blue color. You will see it as a white color whenever even a mild white light is introduced. Okay, what is next is Poggendorf illusion. What you see here? What you see here? Image B. Image B is it's an optical illusion where this is blue line, this is black line, this is red line, right? This black is continuous with red line. Okay, when you put a image or when you put a board in front of this image, what is going to happen now? How this black line is looking continuous with? Black line is in continuation with blue line. So this is an optical illusion. This is called as Poggendorf illusion. Okay, Poggendorf illusion. Poggendorf illusion. The last one is going to be Pulfrich phenomenon. How you are going to see Pulfrich phenomenon? I will show you a video. Okay, first you look directly like this. Okay, then what you're going to do is you're going to close the eyes. Okay, close the eyes and open both the eyes like this, but you have to close with the hand like this, but both the eyes should be kept open and you have to look at the image. Okay, so first what you're going to do, you are going to look with a plain eye. What you see? The image is moving in a single line. Now close your eyes and look at the image. How it moves. How this moves. Did you see it? It moves in elliptical. That is called as full-fridge phenomenon. Okay, full-fridge phenomenon. Understood? That is normally seen in a patient with multiple sclerosis. Okay, normally seen in patients with multiple sclerosis. Okay, so how many of you have done it correctly? Yes, excellent. Many people have done it correctly. Okay. Next question. What is the answer for this question? Foreground is an illusion not seen in any specific condition. So what made you to think the answer as C? Dr. Aishwarya, Dr. Bhuwana? The cataract, frontal balding, then very good, excellent, Dr. Vishnu. It is distal muscle involvement. Okay, distal muscle involvement. Very good. 1D, 2P. Okay, that is what's seen in myotonic dystrophy. Okay, so myotonic dystrophy is 1D, 2P. That is very, very important. Even if I wake you from the middle of the night, you should tell me 1D, 2P. Okay, so DP, you have to remember. Okay, DP. So how this person with myotonic dystrophy will look? They will look like this. Droopy eyes. Okay, and frontal baldness will be there if it is a male. Distal muscle weakness will be there. Okay, so see here, the patient has a characteristic. This is from Harrison. Okay, they themselves call here. You can see here myotonic dystrophy. Two types are there. Okay, type 1 and type 2. Type 1 is going to be distal and type 2 is going to be proximal. Okay, you have to remember the DP. And the patient has a hatched face due to muscle wasting or atrophy. Frontal baldness will be there. Frontal baldness will be there. Okay, frontal baldness will be there. And these patients are going to have wrist finger drops. Okay, and palatal, pharyngeal, and tongue involvement will be there. Okay, and ECGs will show cardiomyopathy features and complete heart block features. Okay, and these patients are going to be diagnosed very importantly based upon the repeats, which is going to be CTG repeats. Okay, CTG repeats due to involvement of DMPK gene. This is seen in myotonic dystrophy type 1. In myotonic dystrophy type 2, it is going to involvement of zinc finger protein 9. Okay, zinc finger protein 9 gene. Okay, then these patients with DM1 and DM2, basically they are going to have involvement of distal and proximal muscle, and this features is going to definitely differentiate these two conditions. If it is going to be distal, then it is going to be myotonic dystrophy type 1. If it is going to be proximal, then it is going to be DM2. Okay, DM2. Then one important thing what you get to see in this patient is slow contraction and relaxation. Okay, slow contraction and relaxation. Okay, so if you tell the patient to hold the fingers, they will have difficulty in holding and releasing. Okay, that will be one difficulty in holding
quickly
and releasing. Okay, you can see the
note the difficulty in quickly releasing the grip. This is called grip
myopathy. And when you do a percussion, you can see the slow contraction and relaxation. Okay, slow contraction, percussion myotonia. Okay, so you can see here when you contract, there is going to be slow contraction and slow relaxation. This is very, very important feature, and you can see the pseudo hypertrophy. Okay, pseudo
Can be
hypertrophy, and when you
elicited that lasts for several seconds.
tap over the muscle,
Note the
there will be a
depression
slow
/ pit
contraction and
formation at the
relaxation.
site of
Okay,
percussion.
that is very, very important to differentiate. Okay, differentiate. Okay, so this is about the proximal and distal myotonic dystrophy, and you people have done a fairly good job, and you have made this as the diagnosis. Okay, and this is not the answer. Okay, next question. Why? What is the diagnosis? Very good, excellent. So this is a case of locked-in syndrome, wherein the patient's ventral pons is getting involved. Okay, so we all know that for horizontal eye movement, midbrain is important. For vertical eye movement, midbrain is important. For horizontal eye movement, pons is important. Okay, pons is important. So what happens here? Whenever the pons is getting involved, this horizontal movement is absent. Okay, but here the reticular activating system is spared. Because the reticular activating system is spared, what is going to happen? The patient is awake, aware about what is happening around him. The only movement he will be able to do is he will be able to move the eyelid up and down. Okay, because of the corticospinal tract is getting involved, posterior column is going to get involved, spinothalamic tract is going to get involved, and spinocerebellar tract is going to get involved. All the sensations will be absent. All the movement will be absent. The only movement is patient will respond by blinking, okay, or moving the eyeball above and below, okay, and the patient will be able to hear everything whatever you talk about him. Okay, so the patient will can't move, can't talk, only blink. Okay, where you saw this person, in which movie you saw? So our Anand character in Munna by MBBS or Vasul Raja MBBS is the locked-in syndrome. Okay, locked-in syndrome. Okay, so you have to be very sure about this. Okay, and it can be due to any cause. Okay, and when you ask the patient name, you can see the pupillary response. Because third nerve is intact, you can see the pupillary response, and you can also tell patient is hearing you. Okay, hearing you. Okay, so how many of you have done it correctly? So in here, so equal distribution of answers, but the correct answer is ventral pons. So now you understood why ventral pons, right? This we will discuss detailed in our regular class. Okay, that next question. So what is the diagnosis? Cerebral venous thrombosis. Many are telling that. Okay, so what made you to look? You looked at this. Okay, this is called empty delta sign. Okay, sometimes you get something like this also. Dense cord sign. Cord sign. Okay, so it made the patient with cortical vein thrombosis. Usually it can be an acquired one or an inherited one. Okay, in your question, if they give the word OCP, okay, or postpartum hormone replacement therapy, then you have to think about cortical vein thrombosis. So we have a lot of causes: hyperhomocystinemia, factor V leader mutation, protein C S deficiency, antithrombin 3 deficiency, or APLA syndrome, or anything like patient is on OCPs, pregnancy. Okay, so those kind of things will provoke or make you to think the patient is having cavernous sinus thrombosis. Cavernous sinus thrombosis. Okay, so what are the things you are going to get in the CT? You are going to get a empty delta sign. Okay, empty delta sign, and along with this, you are going to get a cord sign. Cord sign. Okay, this is very, very important to make a diagnosis. So how many of how you did? Very good. Many have done this correctly. Okay. So hypoxic brain injury, there is no feature suggestive in the CT scan. Okay. What is the answer? So this patient with the ischemic stroke, you are planning for thrombolysis, whether you can go for thrombolysis or not. Okay. So here the key word is this one, thrombolysis. Okay. So answer is A, and most of you have done it correctly. So very good. So what is important here? Okay. So this is again from Harrison, which says whenever a patient having ischemic stroke, okay, there is something called auto regulation is happening. So it will try to maintain the map between 50 to 150 millimeter of mercury. So if you are heroic or adventurous in trying to reduce the BP, this will reduce the map or it will increase the map. It depends on the condition. Okay, so that will be deleterious. For that reason, it will decrease the perfusion. For that reason, you will reduce the BP if it is more than 220 by 120. Okay, if the patient has malignant hypertension, MI, or if the patient is having more than 185 by 110. Okay, 185 by 110. Very good, Dr. Puna. More than 185 by 110, and you are planning for a thrombolytic therapy. Okay, then only you will reduce the BP. And the blood pressure is more than 220 by 110, with the patient having any myocardial infarction or blood pressure is more than 185 by 110, and you are planning for a thrombolysis, then you will reduce the BP. Otherwise, you will not reduce the BP. Okay. Next question. So all of you have done it correctly. Very happy for that. Next question. So what made you to think? You thought because of the lymphocytes, but I will be happy if you tell some other thing. Very good, Dr. Rakshana. Very good, Dr. Vishnu. Very good. Okay, I'm feeling happy when you say the hydrocephalus. Why hydrocephalus? What is the reason for the hydrocephalus? Usually, the TB meningitis can cause something called basal meningitis. Because this is going to involve the meninges, so it is called as leptomeningitis. So because of the exudates, what happens is it causes the obstruction at the level of the CSF drainage pathway or CSF outflow pathway. So what is going to happen is the patient is going to develop hydrocephalus. Okay, hydrocephalus. Okay, so this patient has a TB meningitis with the hydrocephalus. Okay, hydrocephalus. So this patient is having hydrocephalus, and many times what happens is the patient can present with cranial nerve palsies. Cranial nerve palsies. That is also one important sign the patient has cranial nerve palsies. And as I told you, there is going to be thick exudate in the basal meninges, which is going to obstruct the flow of CSF. Okay, so patient can develop hydrocephalus and multiple cranial neuropathies. That is very, very important point to make a diagnosis. Okay, so always these clinching points you have to think about. Okay, clinching points you have to think about. Okay, lymphocytic predilection can be there in anything. It can be there in the carcinomatous meningitis also, CME encephalitis also, cryptococcal meningitis also. But the important thing is here is hydrocephalus. Okay, hydrocephalus. Okay, so this is what tells you the diagnosis, and I'm happy many people have gone for this diagnosis. Since it was a HIV, many people went for CMV encephalitis. Okay, so one more thing, what you would have thought about CMV encephalitis is altered sensorium. Okay, altered sensorium. Altered sensorium can be seen in encephalitis. Any altered sensorium can think about encephalitis, but here the more appropriate answer is going to be tuberculous meningitis. Okay, tuberculous meningitis. So this is very, very important. Okay, so the CT will show hydrocephalus. Okay, arterial infarcts. Okay, and leptomeningeal enhancement. Okay, very, very important. Okay, very, very important. Why B? What made you to think B? So I want the diagnosis. What you are thinking? If you tell this answer, so definitely whichever place you are, I'm going to send you something, some gift. You to send me your address, I will send you a gift. If I get the answer for this. Okay, meningeal carcinomatosis. Paraneoplastic. One finding here very characteristic. Paraneoplastic is correct, but one thing I expect from you, the characteristic finding. Excellent, Dr. Tanuja. You have to send me your address. Okay, I will send you something special. Okay, so Dr. Tanuja, very good, very good. Okay, I'm very happy that she told opsomyoclonus. Rapid involuntary eye movements with myoclonus, it's called as opsomyoclonus. Excellent, excellent. Okay, so usually whenever you hear the word opsomyoclonus, usually in pediatric age group, what disease you will think? It is neuroblastoma, you will think. Okay, so you think about neuroblastoma whenever a child of less than 1 year has this presentation. Okay, very good. Neuroblastoma. Here, in adult, the paraneoplastic feature is because of small cell carcinoma of lung. It is most commonly associated with small cell carcinoma of lung. Okay, which causes opsomyoclonus. Okay, opsomyoclonus. This is opsomyoclonus. The eyeball moves all around. This is called as opsomyoclonus. Yes. So many have done it correctly. Okay. Happy for that. Okay. So what is the next question? What is the answer? So anyone who has attended our class, what symptoms patient is having? Anyone neurology class, what symptoms patient is having? What we call this, what we people call this as what symptoms? For us, what is Vijayakant symptoms? Very good, Vijayakant symptoms. Okay, the patient has Vijayakant symptoms. The guy coming with Vijayakant symptoms lasting for few seconds, less than 100 milliseconds. Okay, and multiple episodes, 30 times per day. Okay, so whenever Vijayakant coming with less than 100 milliseconds with more than 30 times a day, then you will think about SUNT. Right? So this is a case of SUNT. Okay, so SUNT or SUNA. Okay, you have to think, and the drug of choice is going to be lamotrigine. Lamotrigine. So the drug which is given for prophylaxis is going to be lamotrigine. Okay, lamotrigine. Okay, so here also you can see here the drug of choice is going to be lamotrigine. So this tabular column from Harrison, I told few important things you have to remember. Alcohol, cluster headache, male cluster headache, then indomethacin, paroxysmal hemicrania, and multiple episodes sunk. Okay, so this tabular column is very, very important tabular column for your exam. Trigeminal neuralgia, usually you will not have these symptoms. These symptoms you will not have. These symptoms you will not have. Okay, these symptoms you will not have. So, how people have performed? People have gone for indomethacin. Indomethacin is paroxysmal hemicrania. You can also give in hemicrania continua also. Here the answer is lamotrigine. So if it is a trigeminal neuralgia, then you can go for this one. Okay. So this is again an easy question. Very, very easy question. Vigabatrin. Where you give vigabatrin? What was the diagnosis? So if you know the diagnosis only, then you can go for vigabatrin, right? So what was the diagnosis? Where you give vigabatrin? It is West syndrome. Okay, with tuberous sclerosis. What is the drug of choice actually? West syndrome alone, drug of choice? ACTH. Very good. Excellent, Dr. Vishnu. Very good, very good. Okay, but with tuberous sclerosis, we go for vigabatrin, and vigabatrin is known to cause our visual loss. So vigabatrin, vigabatrin. Okay, so vigabatrin is causing visual symptoms, and mechanism of action is it's a GABA transaminase inhibitor. Okay, and this is called vigabatrin. Okay, this is called as vigabatrin. Okay, so vigabatrin. Okay, so this is going to cause vigabatrin used in West syndrome. Okay, it is going to cause permanent concentric peripheral visual field loss, as it damages the retinal photoreceptor. Okay, so this is about vigabatrin. Very easy one. Okay, next question. So how many of you have done it correctly? So most of you have done it correctly, right? Correctly. Okay, so oxcarbazine, it can cause Stevens-Johnson syndrome. Okay, Stevens-Johnson syndrome. Rufimide is a new drug. Okay, so felbamate, what felbamate does? What side effect felbamate? So topiramate and felbamate will cause renal calculi. Sorry, yeah, sorry, it causes weight loss. Weight loss. And felbamate is given with cognitive dysfunction. Okay, whenever a patient with cognitive dysfunction is there, then you will go for felbamate, and it is going to cause weight loss. Topiramate also causes weight loss. Okay, what is the answer for here? A 13-year-old female student was diagnosed with epilepsy at the age of 8 years. She tells you she had seizure on looking at the sun while she was playing, and she is flickering her eyelids, and after that she will become normal. So Dr. Bhuwana told that this is a sunflower syndrome. Okay, why? Since she sees the sun, that's called sunflower syndrome. Actually, this is sunflower syndrome. What is sunflower syndrome? Sunflower syndrome is on seeing the sun, that photosensitive bright light. Okay, it is going to trigger when the person waves the hand in front of the eyes like this. Okay, so that is what called as sunflower syndrome, usually seen between 6 to 8 years of age. And you can see eyelid myoclonus. Eyelid will blink like this. Eyelid myoclonus. So the patient will look like this.
Should get like the big pumpkins now, or start off with the little ones. I just wanted somebody to carve with me.
Whenever she looks at the sun,
here, so
she will develop the seizures, and you can see the eyelid myoclonus also. Eyelid myoclonus also. So this is called sunflower syndrome. What is this? Here there is only eyelid
Which one?
eyelid fluttering alone present.
Not the Roman one, it's the little one in the middle.
You've got a Roman cord.
She is not able to close the eyes and open the eyes. Ocular
I got.
eyelid apraxia is there.
I'll show.
Eyelid apraxia is present. This is called a G1 syndrome. G1 seizure or G1 epilepsy. Okay, so this is called G1
Oh,
epilepsy.
wow, which
okay,
one's that?
so how many of you have done it
That's the
properly?
Roman one, the little one.
So
And
many
where
one
did you
have
find
gone
that?
for absence seizure. Okay, so it is not juvenile absence seizure. This is a sunflower syndrome. Okay, sunflower syndrome. Myoclonic epilepsy, you will get myoclonic jerks. Okay, it will be jerks like this. The patient will have jerks like this. Okay, that is called as myoclonic epilepsy. Okay, myoclonic epilepsy. So in the class, I would have shown you how myoclonic epilepsy looks. So what is the answer for this question? So many have told answer as C, right? C. Okay. What is 4 score? We'll see. Before that, how many of you have done it correctly? So many have gone for 6. Okay, but answer is 7. Why 7? We will see. Okay. So this is called 4 score. Okay. 4 score. We have 4 components. It is similar to our what to say, GCS score. Okay. So extra one here is we are going to have eye response, we are going to see motor response, we are going to see brainstem reflexes, we are going to see, and respiration you are going to see. Okay, so eyelids opened and they are following the command. Okay, eyelid is open but not able to follow the command. Okay, eyelid is closed. Okay, eyelid is closed. Okay, eyelid is closed but open to loud voice. When you talk to them, they open to loud voice. Okay, then eyelid is closed and they open to pain. Eyelid closes even with pain. Okay, so that is one. So our patient develops which score? Our patient has which score? Our patient has 1. Okay, our patient eye response is 1. Okay, motor response. Motor response, the patient flexion response to pain. Okay, flexion response to pain, and the score is 2. Okay, so 1 plus 2. Then brainstem reflexes. Okay, brainstem reflexes is pupillary reflex is present and corneal reflex is absent. Okay, so it should come somewhere around here. So it is 2. Okay, then respiration. Okay, respiration is intubated and the patient breathes irregular. Okay, not intubated and he breathes irregularly. So it comes 2. That's 2. So the answer is 7. Understood? This you have to make some kind of mnemonic to understand. Okay, so if you want, I will make and send you, but this things when you practice every day, then you will be able to understand this. Okay, so the score is 7. So what many people have done, many people have gone for 6, but the answer is 7. Okay, answer is 7. Okay, so next question. Which of the following is not primarily a tauopathy? So you have gone for dementia with the Lewy body. Okay, so how many of you have done it properly? So many have gone for this. Okay, so whenever you have a patient, it can be a degenerative disorder, then it can be a tauopathy, or it can be a alpha synucleopathy. Tauopathy, alpha synucleinopathy. Okay, so it can be a tauopathy or a alpha synucleinopathy. Okay, in tauopathy we have 4 diseases. Okay, the first one is called Alzheimer's disease. Next is frontotemporal dementia. The third one is PSP, progressive supranuclear palsy, and next one is CBD, corticobasal degeneration. Okay, and in alpha synucleinopathy, Parkinson's disease, Lewy body dementia, and multiple system atrophy. Okay, so what is tauopathy or what is uh, alpha synucleinopathy? Tau proteins are microtubules. Okay, microtubules. Okay, and these proteins are important to maintain the integrity and stability of the microtubules. Whenever these proteins become hyperphosphorylated, what is going to happen is they will not be able to support the microtubules, and there will be microtubular breakdown, more or less similar like this. Okay, microtubular breakdown. Okay, and these form tangles will form a mixture like this, and they will form like this. Okay, they will form a clumps like this. When they form a clumps like this, then it is going to be called as bonded tangles. Okay, whenever it is in the choroid plexus, you call it as bonded tangles. Okay, so these are hyperphosphorylated tau proteins, and they correlate with the disease progression. Okay, correlate with the disease progression. And similar thing is alpha synuclein. Okay, alpha synuclein. Whenever alpha synuclein, these are found primarily in neural tissue, and they are soluble fibrils. And whenever they aggregate together, they form insoluble fibrils, and that is going to be toxic to the brain, and they are called as Lewy bodies. They form Lewy bodies, and it is associated with Lewy body dementia. Okay, so this is about tauopathy and synucleinopathy. Okay, then next question is this one. You have to tell me the diagnosis and what made you to think this as the answer. So many people are telling that it is a subependymal astrocytoma. Why? What made you to think like this? So it is a subungual fibroma or point tumor here, which made you to think that this patient is going to have a tuberous sclerosis. Okay, so it is going to be associated with SEGA. What is SEGA? Subependymal giant cell astrocytoma. Okay, so this is from Harrison. Okay, this is from Harrison, which says that a patient with tuberous sclerosis, okay, is going to have mutation in hamartin TSC1 or hamartin gene. TSC1 is going to be type 1 and hamartin is going to be type 2, and this is also called as tuberin gene. Okay, tuberin gene. Okay, so chromosome number 9 and 16. 9 and 16. These patients have seizures, mental retardation, which can be non-specific, adenoma sebaceum, chagrin patch, periungual fibromas, and renal angiomyolipomas, and cardiac rhabdomyomas. And they will have SEGA, subependymal giant cell astrocytoma. Okay, so how to remember this? Okay, so I remember like this as hamartomas, or few people say ash leaf. I remember as hamartoma, which is going to be hamartoma. A for ash leaf spots, M for mind, that is low IQ, A for adenoma sebaceum, then another A for angiomyolipoma, angiomyolipoma, R for renal, R for rhabdomyoma of heart, okay, then hamartoma, T for TSC1 gene or 2 gene, O for autosomal dominant, M for mitral regurgitation, A for astrocytoma, that is going to be our SEGA. Okay, and S for seizures and chagrin patch. Seizures and chagrin patch. So this is hamartomas. Okay, hamartomas. Okay, so this is very, very important. And many what people have done is they have gone for this as answer. Very good. very good selection of answer. So you have understood it very nicely. It is very good thing. Okay. So next question is this one. Again, here there is there is a little might be a controversy, but you can tell the answer. So this is a case of Wilson's disease, right? Wilson's disease. So Wilson's disease is associated with the sunflower cataract, right? Yes. Dystonic posturing is seen. Okay. Genetic testing is not always clinically useful. This usually is the word which is making this as a correct answer. Okay. And upgoing plantas is not seen. Okay. Upgoing plantas is not seen. If you come to the answer here, there many have selected genetic testing is not useful, and if you have gone for upgoing plantas, actually this is not usually useful. Okay, gold standard. Okay, gold standard useful, but not always useful. Okay, every time you cannot do, in every setup you cannot do. Here the more appropriate answer is going to be upgoing plantas. You can ask me why. We know that Wilson's is due to ATP7B protein deficiency. We all know that. And the patient is going to have a defective copper incorporation into apoceruloplasmin. Okay. And these patients are going to have a lot of features like cirrhosis, which is given in the question. Neurological features is going to be due to involvement of the basal ganglia and subcortical areas. The cortex or the internal capsule is not going to get involved. So there is going to be no upgoing plantas. Okay, upgoing plantas. That is very, very important. Okay, that is very, very important. You have to note here. Okay, that is very, very important. You have to note here. Okay, so these patients will have psychiatric features. So patient is receiving chlorpromazine, and this will be the investigation: ceruloplasmin, urinary copper excretion, hepatic copper excretion, and KF ring will be looked for. Okay, KF ring will be looked for. Next question: patient with more of evening pattern of weakness, which is associated with thymoma. So many have gone for A, okay, as answer now. And if you see here, again, many have gone for anti-GQ1 antibody, but few have gone for anti-stated antibody. This is the answer. Okay. So this is associated with myasthenia gravis. As day progresses, the weakness increases. Okay. GQ1, Miller-Fisher syndrome, anti-MAG antibody or MOG antibody is associated with multiple sclerosis, and anti-Hu body is associated with paraneoplastic cerebellar syndromes. Okay. So here answer is myasthenia gravis. So what our Harrison says that the most common antibody is going to be anti-acetylcholine receptor antibody. Okay. Apart from that, we have anti-MuSK antibodies. Okay, anti-MuSK antibodies, and apart from that, we have anti-LRP4 antibody, and we also have anti-agrine antibody. Okay, so LRP4 antibody or striated muscle antibody is seen. Okay, striated muscle antibody is seen. So this makes the diagnosis as anti-striated muscle antibody. Okay, hope you are clear. Okay, so with this we are finishing neurology. Okay, so I will give you some time break. After break we will continue with endocrinology. I will give you how much time you want? 5 minutes. How much time you want as break? 5 minutes. How was your experience with neurology questions? How was your experience with neurology questions? How do you find it? So happy that you enjoyed neurology. Okay, so after this we have endocrinology. Okay, so after endocrinology we'll finish the class. Okay, so once you attend neuro class it will be more easy, I think so. Okay, so bladder innervation syndromes I will definitely teach in the class. Okay, so 15 minutes break you want. Another 30 questions are there. Okay, so we will try to finish. 10 minutes is enough, I think. We'll finish neurology. Endocrinology is not so tough. I think we'll finish it fastly. Okay, 10 minutes break we can go, then we'll start again. Ten minutes. Okay, so what is the time now? The time now is 6:23. We will meet again at 6:35. Okay, 6 So again, we will start with our discussion. If your people are ready, then we will go for the next discussion part. Okay, so we'll start now. So this session, we are going to go with the next important thing, in endocrinology. Okay, so endocrinology is going to be again a fascinating one. So here, the first question is a 78-year-old, female patient, osteoporosis, progressive dysphagia to solids, especially meat. Weight loss is there, and appetite is good, and otherwise nothing is remarkable. So what is this patient is suffering from? What is this patient is suffering from? So this patient is an osteoporotic patient who was started on treatment. Okay, she was started on bisphosphonates. Bisphosphonates is known to cause pill esophagitis, especially when you start on oral bisphosphonates, okay, what is going to happen is this is going to cause pill esophagitis and the patient will develop dysphagia, okay, dysphagia. For that reason only, what you will advise is whenever you have a patient with on bisphosphonates, you will tell the patient to sit erect, take tablet, drink a glass of water and sit erect for at least half an hour to 1 hour in a erect posture, not to lie down. Okay. So for that reason, this is patient is having bisphosphonates induced pill esophagitis. Because of that, the patient is not able to swallow. Okay. So post-menopausal osteoporosis, we have our drug of choice as bisphosphonates. Okay. And these are known to cause esophageal disorders in the form of stricture, varices, and Barrett's esophagus. And this patient should stay upright for at least 30 minutes. Okay. So this is very, very important advice you will give to the patient. Okay. So this is from an article I have taken. Okay. This article also says that this causes esophageal erosion or irritation. So pill esophagitis is more common with the oral bisphosphonate. So you have to be very careful about it. Okay. So what you people have answered? Yes, you people have answered it correctly. The patient was started on bisphosphonates. So this is the correct answer. Okay. So very good. We'll go to the next question. Here, the answer is little easy, but you have to tell me the diagnosis. Here, the answer is easy one, but tell me the diagnosis. A elderly female, history of lethargy, feeling very cold, GCS poor, hypothermia, hypotension, hyporeflexia, non-pitting edema. So she is a case of thyroid disorder, now coming in acute crisis, which is going to be a mixed edema coma. Okay, so here the answer is going to be thyroid function test, as you told correctly. This is going to be a case of mixed edema coma. So you have to go for thyroid function test. Okay, thyroid function test. Very good. You people have attended it very nicely. But why mixed edema coma? Okay, so this patient is coming in mixed edema coma or crisis like this. And once you start treatment, the patient will smile at you like this. Okay, so this is mixed edema coma or crisis, but it is easy to say, but very difficult to follow. Okay, so what Harrison says, so it has 20 to 40% mortality even in this new era of treatment. Okay, and you do a LFT to confirm it is a hypothyroid patient, but irrespective of T4 TSH levels, there is no prognosticating levels. But if the patient has a hypothyroid picture, then highly likely that patient has mixed edema coma, and the patient has reduced level of consciousness, seizures, and hypothermia. Okay, hypothermia. There may be a history of treated hypothyroidism with poor compliance. Okay, and the patient will have some kind of predisposing factors. Okay, so whenever a patient comes in mixed edema crisis, okay, it is all hypo. All hypos will be there, with the hypo consciousness will be there. Hypo consciousness will be there. Okay, so it is usually precipitated by some infections, non-compliance to treatment, neurological factors or cardiological diseases, and always the treatment is going to be give IV T4. Okay, it is not readily available many times. Okay, and you can give IV T3 also. If it is an emergency, then you can go for IV T3 also. Okay, sometimes what people do is they because T4 has to get converted into T3, and many times this conversion will not happen. Okay, for that reason you give directly T3. And sometimes what happens is it is not available, means what you can do is you can take the thyroxine tablet at high doses, you can crush it and give through Riles tube also. Okay, but still the mortality is 20 to 40%. Okay, 20 to 40%. So you people have told that it is mixed edema coma correctly. So the next question is this one. What is the answer? Why? So this patient, okay. So whenever you have I will come to the answer. Okay, may I come to the answer. So it is subacute thyroiditis you have told. So how many people have done it correctly? So many people have gone for Hashimoto's, but the answer is subacute thyroiditis. Okay, subacute thyroiditis. Okay, so this patient has thyrotoxicosis with a reduced uptake. Okay, so whenever you have a patient with the clinical feature of RAYU, okay, sorry, clinical feature of thyrotoxicosis. So thyrotoxicosis is there. Then what you are going to do is you are going to plan for a RAYU, radioiodine uptake study. Okay, so whenever you plan for a radioiodine uptake study, okay, radioiodine uptake study, so you see whether it is increased uptake or a low uptake. If the gland is hyper functioning, then it will take more hormone, more RAYU. If it is hypofunctioning, then it will take less RAYU. Okay. Now, what you're going to do is, if it is an increased uptake, see the pattern of involvement. Okay. Whenever it is a homogeneous involvement of increased uptake, then it is going to be Graves. Okay. Whenever it is a heterogeneous intake, if it is like a one area intake, then it is going to be solitary thyroid adenoma. If it is going to be a multifocal uptake, then it is going to be a multinodular goiter. Okay. Then next is reduced uptake. If there is a reduced uptake and you suspect it as a thyroid disease, then it is going to be many times thyroiditis. Okay, thyroiditis. In Hashimoto's, there can be a mixed picture because initially there will be a hyperfunctioning. Even though hyperfunctioning, the patient will have increased T4 initially, followed by decreased T4, T3. Okay, so once the patient has a decreased T4, the thyrotoxic features will decrease. Okay, so this is ruled out because of the thyrotoxic feature. So as you told the answer, I'm telling that this is not the answer. And if it is going to be a decreased uptake, there is going to be a decreased uptake. Okay, then next is, if it is going to be extrathyroidal involvement and decreased uptake, then you have two options. It can be an endogenous involvement or an exogenous involvement. Endogenous means it is because of struma ovary, where the patient is going to have a ovary producing hormone. Okay, so here the thyroglobulin is increased. Okay, and if it is an exogenous one, okay, then it is going to be a case of thyrotoxicosis ataxia. Okay, where the patient gland is not functioning so normally, so there is going to be not much uptake or normal uptake is going to be there, and the patient is taking the hormone or the tablet from outside. Because of that, the patient is having thyrotoxicosis feature. If you check for thyroglobulin in this patient, the level will be low. So this is how you will differentiate different kinds of RAYU. Okay, different kinds of RAYU, and I will show you one picture. You tell me how you are going to differentiate. Okay, so what is this picture? First one indicates. What is this picture indicates? Diffuse homogeneous uptake. Graves' disease. Second one. Second one is going to be MNG. Third one. Solitary thyroid adenoma. Okay, nodule. Patchy heterogeneous uptake. Then it is going to be a thyroiditis. Okay, thyroiditis. Okay, more commonly subacute thyroiditis you can go for. Okay, Hashimoto's, it's not usually confirmed with this. Okay, so you go for a subacute thyroiditis. Okay, so this is about the how to evaluate a patient based on the RAYU. Okay, hope you understood this. Okay, so we'll go to the next question. A 50-year-old male is seen complaining of stiffness and reduced movements by